Test, test, 1, 2, 3. Test, test, 3, 2, 1.
Budget retreat at 1300 hours, 1 p.m., Friday, July 16th, 2021. And if we may, Leanne, if you'd start with the opening prayer.
Thank you. Good afternoon. Sharon said to make this prayer a good one, so the pressure's on.
I couldn't hear that. What?
She said Sharon told her to make sure it was a good prayer.
Let us pray. As we gather together this afternoon, let us be cognizant of and grateful for all the resources entrusted to us. Live into this amazing strategic plan. So we ask for collective wisdom, understanding, insight, and discernment in determining the best allocation of these resources. Focus us on our mission, align us in our commitment, and enable us to do the highest good possible for all. All this we pray in your holy name. Amen.
Amen. Yup. What'd you say? Oh.
I think that prayer worked.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Jeffrey, thank you. All right. We have any citizens?
No citizens.
Then we're up to item Roman numeral 4, other matters requiring board discussion. And Robert, I'll turn it over to you.
Okay. Let me give you all a bit of an overview of what you're going to see today. Lauren and I are going to talk after Sharon comes up, but I wanted to give you guys an idea of sort of the format today and set the parameters of our discussion. We've had these before, and our budget retreats are always profitable, I think, for staff and hopefully profitable for you all. Today, what you're going to do is you're going to see the beginnings of the strategic plan, and that strategic plan, Reverend Emerson, is that backdrop. And we're going to use that to look at how we begin to operationalize the budget. Now, everything in the strategic plan is not budget-oriented. So what we're going to do is the presenters today will begin to highlight things for you and give you an idea what relates to the budget and give you an idea of what we're doing and pull out those things that are budget matters. This is the preliminary stage of this, so you're not going to get, we're going to bring on 42 FTEs to do this, or this is going to be a 3% increase over this. What you will see is we thought we would open with some opening comments from Sharon. And after opening comments from Sharon, because your CFO is always going to direct and lead your efforts on anything that we're doing. So Sharon is the one that we turn to, and Sharon is the one that at times people turn away from. So Sharon is the person that controls and deals with this. So Sharon will make some opening comments. And then what we thought we would do, Mr. Bose, is take our opportunity to bring the Acclaim Consulting Group in. And DT, this I think is going to be helpful because this is the first time since we've had the consulting group working on the Acclaim group to come in and give you all a perspective. Dr. Becker is with us. Dr. Becker has been here 4 days, and he will be making the bulk of the entire presentation today. So Dr. Becker has done his best to make sure that he is up to speed, but if you all would allow him the opportunity to realize that he has been here 4 days. And Jay York from our group Guidehouse will be here, and we will tell you everything that we currently know, and we'll be very upfront with you about where Acclaim is and what we're doing and where we're going with that. We're going to vary just slightly on the agenda. We're going to ask Joy and David Mendenhall to really talk about care models. And the reason that we did that and the reason we put that together is everything in care models has a backdrop of data. Everything that we're going to do in the care models, particularly this first year, is going to be data-driven and data analytics. So some of the budget requests that you all will be getting in the actual budget will be IT and technology related. I think that will help. And then we're going to end today's presentation with what we think is the most important, and that is none of this can be accomplished if you don't have a strong employee base. And if we're not working on the best places to work, and we're not working at keeping, retaining, recruiting the best people in this organization, I want to emphasize the recruitment and the retention of who we have. This is not an organization that's going to start just recruiting people. It's an important aspect to retain who you have. Any of you all who have worked on not only this budget in the past, but as Mr. Petty can tell you and others, it costs a lot of money to retrain folks. So if we can retain who we have good people, we like our teams. If we can retain them, that's going to be a big factor in the go forward. So Karen Duncan, and she'll be happy to tell you that she is probably the most unlikely candidate to come up and talk about HR type related issues. Because as Karen said before, she was the one that usually got pulled in front of HR, but now she'll be leading our HR presentation today. Yeah, our chair said he was right behind you. I don't know which chicken and which egg came first on that one, but to that point, we really feel that we're going to present to you all a good beginning, but we don't want y'all to think this is the end. Zim, I want to let you know that the challenges that we have here is you got the Guidehouse report because, one, you got an outside consultant that's doing a really good job, but we worked hard to work with them and tried to get as much paperwork together as we could. But I will tell you that sometimes for staff it is tough to get everything 1 week, 2 weeks, 3 weeks in advance when it moves as fast as it does in JPS land. And if y'all know, we just left you from the last board meeting, and we love to be around y'all, but sometimes it's tough to kick it out quick enough to get that in y'all's boxes and in the portal a week in advance. So the information that you're going to get today is not of the nature that there is a study measure to it. So I wanted you all to know that we're going to get you as much information as quickly as we can. I want to thank Mr. York and his efforts to get us information the best he could from a third party outside. We made some changes. Daphne took a look at things, and Daphne's expertise has been hugely helpful. So we had a few tweaks in some of the presentations, and that's why you got it a little bit later, but nothing of any magnitude changed with any of those reports. So without further ado, I would like Sharon to begin with some opening remarks, and she's going to lead right into Lauren. Lauren Poe, as you know, is our Executive Director of Strategic Planning. You got to know Lauren really well when we had our retreat, and you all helped write this plan that is before you and write the plan that's guiding our budget. So Lauren's got 2 slides that she'll share with you, and then we'll go into the presentation that Joy and David will be giving. So Sharon, please take over.
So first of all, I want to thank the board for dedicating this afternoon and next Friday afternoon to the budget. It will make, I think, the presentation on the 12th at the full Board of Managers as we try to get budget approval a lot easier. I think it'll give you a lot of insight as to what we felt like was important. As in any budget year, we kicked off the budget in March. As soon as we close March, we start looking at volumes, we start talking to our directors, we talk to vice presidents, we talk to the managers, we involve our physician leaders, and volumes are really what drives the majority of our budget. Over half of our total expenses is salaries and benefits. You've got another 15% in supplies. You've got another 15% in those physician coverages that are required within the medical center walls. And then you have all the fixed expenses, the facility expenses. So when you look at our budget, we can get that done fairly quickly. We've layered on a lot of different assumptions, but this year a lot of the focuses that we'll have, and Robert kind of stole my thunder on this a bit, but you're going to hear about things that bubbled up through this strategic plan. We're going to talk about access today. We're going to talk about care models. We're going to talk about how we mine data, how we use data, and most importantly, the workforce. And I will say that it's an interesting year with just Karen and I looking at HR, but I think we've come to some really good recommendations. So I'm excited for you guys to hear about those. Next Friday's budget retreat, at least preliminarily, unless you want to see something really different, let me know. We're going to talk about a lot of the revenue. I need to spend a lot of time with you guys on supplemental funding. There are major changes that are coming our way. It's fruit basket turnover. All the programs are called something different. So come with an open, ready to hear mind next Friday, because that will be alphabet soup by the time we finish with that. I'll also share with you some property tax assumptions and where we stand there. I want to bring you up to speed on our COVID relief funds that we received over the last 24 months. You're going to hear from Rory about revenue cycle. We promised to bring you a little bit of review there. And he's going to share a couple of good initiatives that have a pretty big budget impact for us next year in a positive way. Tony Banda, our VP of Finance, is going to start to cover kind of net revenue, volumes, payer mix assumptions, and then I'll give you a very high-level review of capital so you kind of understand what we're doing there. Is there any questions that I can answer for you guys? No? Okay. Thank you.
All right, thank you guys. So as Robert mentioned, the strategic plan really did serve as our backdrop as part of the budget process this year. And so just going to give you a couple of remarks on that so that leading into these discussions, you can kind of see how that all fits together. As we've started to operationalize our work related to the strategic plan that you approved in May, the OSM has worked with the executive leadership to assign executive champions over each one of the strategic priorities that you see outlined in the plan. Those executive champions have been tasked with developing multidisciplinary work groups across the network, consistent of employees, frontline team members, leaders, as well as clinicians. And their role will be to start to operationalize the initiatives, the strategic initiatives in the plan. This is a new plan, a new strategic plan, and so with that, it outlines a lot of new things for us here at JPS, of course, and new things, a new way of doing things. So since FY22 is the first year of implementing this plan, there are going to be a lot of assessments done as part of this first year before we start to implement those new models or new things. And so what you're going to see is a lot of the work prioritized in this first year is really laying the foundation for then those new things that we talked about in the strategic plan actually getting accomplished. And so over this first year, those implementation teams are going to be working on things such as patient journey mapping, a lot of patient journey advisory groups, a lot of other initiatives throughout the year. But like Robert mentioned, what you're going to hear today are truly those things that are tied to a budget ask in FY22. And so Robert did a great job explaining that a second ago, that there's going to be more work being done throughout the year, so we just want you to know that. But the nature of today's discussion is really going to be focused on those items that have budgetary asks that you're going to see come forward in the budget process. And so each one of these, on the slide in front of you, what you have, and it's in your packet as well, that's just an overview summary, one-page summary of the strategic plan, so it should look very familiar to you guys. And we just wanted to highlight for you those areas of focus for FY22 that do have those budget asks. And so those are indicated on that slide with those blue stars. And so we're going to start out the day. Robert so eloquently mentioned this, but just quickly to tie it back to the plan, we'll start off the day hearing from, like he said, Dr. Becker and Jay York from Guidehouse, talking about the first step in becoming that integrated healthcare delivery system that's outlined in Strategic Priority 1.4 there on the slide. After we talk about that, you're then going to hear from Joy as she talks about some of those key foundational elements of access, which is the strategic enabler that you see in the plan related to reimagining access, because ultimately we've got to look at our access models in order for us to start building those care models of the future. And then David, like Robert mentioned, is going to dovetail into that conversation and give you an insight of those things related to the data-driven and technology-enabled organization strategic enabler that we talked about, that are going to marry with the work that Joy and the teams are going to be doing around access, and then ultimately setting the foundation for building those care models that we've talked about building in the future. And then, like Robert said, lastly, we're going to end the day with Dr. Duncan, and she is, again, going to talk about, you heard both Sharon and Robert, now I'm going to say it again because it is the most important part of this strategic plan, and which is when you remember that compass. I see Dorothy and I guess Charlie has a printed copy in front of you. That compass, the reason that we made that compass like it is, with the foundational element at the bottom being the best place to work, is because without that, none of this strategic plan works. So we'll end the day hearing Dr. Duncan talk about what we're going to focus on in FY22 related to our workforce and being the best place to work. So thank you.
If you all will allow us, we're going to have Dr. Becker. We're changing the schedule, if y'all will permit us. We're going to have Dr. Becker and Mr. York come up, because we felt that if we kept Dr. Becker last, he might leave before that. So we wanted him to present now so he can't leave. So Mr. York and Dr. Becker. And Reverend Emerson, did you have a question?
Yeah, I have one for Lauren. Did she run out and duck out? Oh. Just my question is, when we look at this strategic plan, is it a date attached to this, or it's not dated?
Dated? Is that date? Are you talking about a time frame?
Yeah, I mean, this is together that will carry us, say, the next 5, next 7, next 10 years.
Sure. So, and I don't know if you want to kind of talk about that, but whenever we went down this path, Robert and I had a discussion about this being an organic strategic plan from the standpoint of not putting an exact number of years on it. It is a multi-year plan, though. We definitely, it's a multi-year, but the number of years, if you want to talk about that.
We were going to two things. One is, as you all know from the retreat, what we did was we shifted from those pillars and created a process that we think is a whole lot more beneficial, much more beneficial for the organization in the strategic plan. But we purposely didn't say this is the 5-year strategic plan, but where we see it as its evolution. This year, you're getting the beginning of it. We'll add to it next year. We'll add to it next year. This will be the framework by which we move forward. So you could say this, in all likelihood, would be a 3-year framework as we begin to look at that, and then make a serious restructure or a reconsideration if we want to look. But we think strongly that we've got the right strategic plan for y'all's inclusion in it, the staff's inclusion in it. So I really see it as a strong 3-year plan with a strong reevaluation.
And Reverend Emerson, we've built into the process, because I know you guys really asked us about a process, right? Not just creating a document. And so what we've built in the background on the process is we do have internal triggers, because we know healthcare changes. None of us expected a pandemic. And so every year, to Robert's point, we'll be evaluating the plan and what priorities within the plan we as an organization and you as a board want to focus on each year. But in the background, the OSM, that's their function, is we'll be responsible for looking at trends, right, within the healthcare industry. And if there's something big that's happening that may need for us to trigger re-looking at the entire plan as a whole before that 3-year mark, then that we're set up to do so. So we'll be tracking trends in healthcare appropriately, so that if something big such as Texas expanding Medicaid, right, that would be something very big that would warn us.
That would be pretty big.
Yes.
That would be
big. Things of that nature that happen, those would be triggers that would lead us into a reevaluation of the whole whole plan.
Okay, yeah, I'm with you. The reason I asked that is because I think this also plays a key part entrenched in the executive group that has been formed, because it's like we're saying, does this meet what the plan says, or is the plan now lined up to address where the committee is thinking? And that's when I asked that, so that we would keep.
What we did, Reverend, at the last strategic plan meeting last Friday, Dorothy and Roger and Trent and myself did just that. We did the same exact thing. We did a strategic plan backdrop to what we were doing with the bond, and I think it aligns very well.
When I look at this, I'm thinking that, Ralph, that the broad goals they have here, we're not gonna be able to accomplish them in 1 year. So it's gonna take you maybe 5 years out to really become that best place to work, because we gotta put certain things in place, so that would make it expand. With the facility plan, that's the one that I think is not on here, that we know we're gonna be working on it, and it dovetail into this. So it would be one of those stars to me that would be there. And we're talking about where we're starting, 1 year, 2 years, 5 years, 10 years. So I don't see your strategic plan, as things happen, you will incorporate that, including if they do expand Medicare. That's no more than another delivery care model that would fit right into your overall strategic plan. So I think we have the elements there that would allow us to say, here's where we want to be 5 years from now, where we might have to change some things as it comes up. Okay.
Yeah, a lot of it too, Ralph, is going to be, it's going to dictate timing as much as anything, because part of what we're relying on from Guidehouse and Price Waterhouse is to be able to illustrate to us from a facility standpoint when these revenue streams come in that are available.
Right.
For us to be able to use, so that when we do jump out there and begin building facilities, we've got a good financial plan approaching it. So part of what Sharon's gonna tell us next week is crucial too, because to the extent supplemental funding changes, that might give us the opportunity to, move up some of those more critical components of the facilities plan too.
The one I'm struggling with, and maybe as we move forward, we be able to give some visibility, is I have a problem. I have a little bit challenge of following to see what is our baseline, right? What's our 2020, 2021, because 2021 is always going to be an outlier year. So we need to know what's 2020, and then leapfrog to 2022, 2023. And then how are we going to address, like the baseline? What is our panel for that physician panel look like? What are we going to try to increase through efficiency? Can we add supplement PA and all that stuff to increase that panel, right? National average is about 2,300 or 2,500 per physician.
Sure.
Technically, we should not, based on that formula, we should have 16.5.8 primary care physician. We have a lot more than that. So we have other book of business also as well. So understanding, our commercial business, understanding our Medicare, Medicaid, and our self-pay, so that we can see what's our book of business, how do we staff them, and then what drives other stuff, right? What is our current spend on drug today, right? How many of that percentage is going to be brand versus generic? And then are we going to improve on chronic care condition and all that stuff, so that we can apply the polypharmacy, so that we can bring the cost down, all that stuff, so that we can negotiate, and then what's the headwinds going to look like, right? Because if we are way behind our other hospital in the space. So obviously they're more advanced on the value-based, moving more toward risk-based type thing. And we haven't even started pay for reporting yet from the HEDIS measure and outcome measure and all that stuff. As we go down that path, how do we get smarter so that we can find the rising risk and all that stuff from the patient themselves, to be able to say insurance if we're gonna split the premium dollar, I have this much sicker patient here, so how you gonna compensate me to take care of them? Otherwise, the other hospital will gather all the healthy population, all that stuff, and then we're gonna have to deal with very expensive. And it doesn't matter how much we got paid at the top range, we can't do that. And then what do we do with the ACC we capture? So make sure that we capture all that stuff to get paid correctly and all that stuff. So that way we can arm our people to negotiate better. Lack of that, we're gonna beat up on our physician and say, it's a race to the bottom. And that we can turn around, we're gonna suffer just like ACA today. ACA lost 80-something% PCP as of this morning from one of the hospitals. So those are some of the things that I haven't seen overlay reality to this. Maybe we will get there, but I think it would be more helpful for me to see that and set the goal for us to go forward. I think that was in English.
No. Well, no, I didn't know how we want, there's several points there to address, so I didn't know. I can speak to the value base, but.
Healthcare, we can say whatever we want, right? I haven't seen anything. I've been in healthcare since almost 40 years now. Nothing back in the 70s and 80s and now have changed yet. We saw HMO, we saw PPO. HMO is nothing different than the word we use today, which is value-based care, right? Instead of beating up on the lab and all that stuff, you reward back now. You fill out, quality measure and all this stuff, and then any saving left, we share back with you. And then back then we have PPO. PPO is nothing different than what we call network optimization, right? Who's the best physician specialist we refer to drive the cost down, get better outcome. Now we have more data. But the worst thing about healthcare is that the more data we have, the more confused we are. So how do we make sense of that and negotiate? And then we know we can't compete with other hospitals, but we are population health management. We take care of the population in this area, so it fall where it may. We just negotiate on the population, and then that'll drive our decision and service contract so that we can get paid. And the best way I can explain is this. Like, as a physician, you spend 12, 16 years in school and training, and you get to the point where we are the best of the best in the world. So why are we doing all this service, and then we have to get down on our knee and beg the insurance for mercy and pay us? If we understand the risk of that population, we can sit at the table and say, I know this risk of this population, I know the post-acute care, I know every aspect of that. Let's negotiate how much premium you're willing to give me so I can take care of them and improve their health. That's all we're trying to do, I think, in a nutshell.
So, DT, let me try to answer like 3 of those 100 questions. So I think we have talked a lot about that internally. I think the very end result is those risk contracts, right? But we've got some work to do, and you're going to hear a lot about that today through some of the data management in the next presentations after Guidehouse. You're going to hear about our planning for access as well as care management. So I think what you're talking about is kind of the end result of all of that when we get these systems built. From my standpoint and from a risk revenue standpoint, we'll be ready to take on that upside and downside risk. We've talked a lot about the connection population is a great group for us to start that with. So we may not answer all of those questions today, but we have started to address them. So hopefully you'll hear some things that will help answer that concern.
Maybe what we can do, DT, is after today's presentation, we can revisit your question and try to figure out what else we didn't answer or what we didn't do. I also want to recognize staff, all of you that are here. I did recognize your faces while DT was asking that question. I noticed all of your faces going, well, maybe Sharon can answer that. And then all of y'all looked at each other and then all looked at Jay York and said, get the consultant to do it. He lives in Ohio. So we appreciate it, but let's go through this process and then let's revisit your question and see what else we didn't answer. But you basically asked the question, which is the crux of the whole presentation today, next week, and budget. So, thank you.
That's the end result we're hoping to get to. Thank you.
Super.
Thank you.
With that introduction, Jay, why don't you and Dr. Becker take over? With the answer. Yeah, there you go.
Steve, Ohio State.
Great.
Yeah, another one.
Try from here. Okay. So I think first of all, this is the first chance that I've had to meet many of you in person and really appreciate the opportunity to share, what we've been working on, what we found so far. In many cases, as we, talked to the search committee, when we were proposing this project, if you look at how consultants work, a lot of things that come out where I asked to identify and analyze opportunities. These things are going to come across in many ways as financial opportunities or operational things, but I would keep in mind that, and I can tell you this with 100% confidence, that as we've looked at JPS and Acclaim, there's nothing in this that really doesn't point to better patient care. And so, again, a lot of times when you're trying to really focus on that aspect of it, the numbers and things get in the way. Even some of the discussion today is focused around, that financial piece and how you better support the organization. But I think, keep in mind that it's about primarily taking care of your patients better. So with that said, I think we wanted to jump in and just talk to you a little bit about, some of the themes that we have started to delineate. First one is really the fact that, as you're looking at the financials and again, looking at how Acclaim plays into the overall network, the typical physician groups have a net loss on their books. And so as that, becomes a concern or question for you going forward, yes, there has been some transition between 19, 20, and now 21. A lot of that's really tied to COVID. And so that's across the country. What we've seen in many cases is huge dips in, revenue and productivity and things like that. 21 is starting to improve, which is a good sign for you. And in addition to that, there's a big contributor in terms of number of providers that have been added. So when that is factored in and you start to look at the strategic value overall, it speaks to how you're able to provide that care that I mentioned and then where that can be provided in your number of sites. So that's point number one. I think the second part that I want to mention here is really when you think about investment in a medical group, that's a very typical process that health systems go through, whether that is a direct employment, a partnership, or a professional services agreement. And that's what we're seeing with JPS. That investment in the group is of huge benefit. There are not many alternatives. You don't have the ability to start bringing in completely independent physicians to serve the population that you do, and you do a great job at it. There's opportunity, but I think that's something to keep in mind, that really to look at the full strategic value of the group has to be captured and not looked at in isolation. And then, so the last piece, and again, it's not solely the last piece, but if you look at the market forces and changes in facility-based billing, some of the things that are going to continue to evolve are going to really require a much more tightly integrated group. And that's been one of the goals all along, is to look at alignment and integration. And that takes on a number of functions, whether that's operational, whether that's strategic, whether that's even, at the physician level. So that strength and partnership is really going to be critical going forward. So again, I think that as we dive into the next couple of slides, you're going to see more and more about this alignment. You're going to see some of the opportunities to improve patient access and operational workflows. And ultimately, we're going to talk to you a little bit about the next phase of work as we're starting to wrap up the assessment phase and moving into compensation redesign. I wouldn't look at it as compensation redesign solely for the point of redesign. It's really about alignment again within the organization, because these things have to drive the right, strategic function. So with that, I will give you a little bit of overview on where we've been. So if our goal has really been to evaluate and analyze a claim's current performance, looking at the operating model and that alignment, the physician comp plan, and then the overall, strategic positioning of a claim, we've had a lot of opportunity to complete over 30 interviews. It's been great with physician, administrator, some of the board members. It was very helpful for us to get a great insight into the organization, as well as to pull some themes that were able to allow us to deep dive into some of the analytics. So as we've been continuing down that path, and I'll say got smarter on the organization, we have dug in a little deeper and gotten, very detailed analyses done. And that's led us to, so it's interviews, analysis, and then site visits. So we like to see things firsthand. And so we can be told, how things work, but it's always helpful to have that opportunity to interact. And then so as we look at the, final deliverable on this, it's really about that assessment and empowering decision-making that we talked about at the very beginning of the proposal to you all, and how this ties into strategy. So the strategic plan that you have developed has been at the forefront of our goal to, make sure we've tied into. For those of you that saw the assessment framework, again, we don't need to necessarily dive into each of these bullets, but just know that we take a very comprehensive approach to this. So as we look at revenue drivers, operational and expense drivers, we marry those things up to come up with a story that will help, us start to delineate where the issues are and what the opportunities may be. So these are all the areas that we've dived into and continue to articulate out in our analysis. So where has that led us? So one of the things that we have shared, with the administrative team, and I unfortunately can't read far enough away, so I'm going to look down here. Really the core themes that we've really started to align around become organizational alignment and integration that we mentioned, looking at access to care in the network, and then operational delivery models. So if you think about these, it really does start to bifurcate into an operational piece, which we'll talk about a little bit more in a minute, which is really internally focused. And then if you think about the strategic focus, which becomes more the external component, those two pieces for a claim are going to be ultimately important going forward to, drive that better alignment. So as you can see on this slide, we've talked about the buckets that we've really started to categorize the primary issues into, and they become, what are your strategic issues? What are the organizational issues? What are the operational issues? And what are the financial issues? And so when we look at the overall, future role of a claim and how it can best support JPS, that becomes, one of the primary strategic drivers. An overall lack of, physician engagement, if you don't, include the physicians in the decision-making, if you don't really leverage that expertise, will negatively impact overall recruitment and retention. And then ultimately, that's the, what we call the strategic value of a claim, which to this point has not been clearly defined. I feel like that's a key point that if you look at a medical group in isolation, you're not really getting the full picture, and we see that time and time again. So I think, it's, again, as we segue down through some of the other aspects, it becomes, pretty clear that there are, operating model, opportunities when we look at the workflows and even the functions within the clinics. And again, this spans not only the acclaim piece, but the partnership with community health and how they, work together and drive, again, patient access and care. The financial piece to that becomes, opportunities to improve revenue and margin, to, the opportunity to, it's not just about working harder. It's not about productivity alone. It's about new revenue streams. It's about looking at contracting opportunities and, you know, looking at value-based care that you mentioned. I mean, it's looking at the future and how do you continue to evolve this model? And then overall service and program development. I mean, this is a huge opportunity that as services have developed in, I'll say in isolation, basically in the current service line structure, to become more integrated, to be able to connect these from an acclaim perspective as well as an outpatient facility and inpatient perspective is going to help drive care across the county. And then lastly, just thinking about overall, you know, lack of standardization, there's opportunity. It's a maturity question in our minds. I mean, again, knowing what we know today about how a claim was brought together and some of those challenges, now we're looking at, you know, version 2.0, if you will, to have that organization mature and move forward. Dr. Becker's obviously going to be a key piece to that. And as we have started to have conversations, I think that being able to provide him, you know, our insights, you know, from an objective third-party standpoint, for him to be able to talk to his team and this organization are going to help him to, you know, drive that forward. Let me pause for a minute and see if there are any questions so far.
A couple questions. Thanks for this. This is very insightful. After you make these findings and come up with recommendations, I'm assuming, in terms of how to cure some of these challenges. And,
yes, sir.
What will that look like? Will it be some to claim management, some to hospital management, and some to this board in terms of recommendations that each of us may take?
Yeah, so typically what will happen, and again, I'll say we're sparing you a little bit of the detail today because we're still finalizing some of this and making sure that this is aligned. We will typically look at where that opportunity lives, you know, and again, is that we've tried to focus our assessment on the acclaim piece, but again, it would be short-sighted of us not to connect the dots. And so as we work with Dr. Becker and, you know, Robert and Karen across all of these areas, then we're able to articulate each of those, you know, by area. And I think again, we get very specific on those things and give you the opportunity to prioritize.
Right. And based on your experience of looking at these around the country, I mean, is this typical kind of stuff you're finding? Is it at this stage in our growth of a claim? Is it?
It really is. And I don't say that lightly. And I don't say it to not be specific in your you know, organization. It really is. What we find is the broad opportunities are usually very similar.
Okay.
The reasons behind them are different. And so, again, whether it's, you know, access, whether it's productivity, whether it is just overall organizational alignment, every organization tends to have its own culture. And, you know, we work with organizations that it's very hard to get the physicians aligned because they seem to think very differently. In this organization, you know, what we're finding is that everyone, and again, I say this very seriously, is unbelievably passionate about taking care of this patient population as well as teaching. I think they see those as inseparable. And that's very admirable. I think, you know, when we work with children's hospitals and rural hospitals and safety net hospitals, the North Star is always there. And so I think that, you know, again, finding the right solution is not cookie cutter, but, you know, again, the replicability of the issues gives us a lot of insight into how to do that.
Yeah. But we all want to get it better, so
Right.
I appreciate that and look
Sure.
forward to the recommendations. Thank you.
Thank you.
You first.
What we try to do is, you know, at the end of the day, we want.
Pull mine over.
Dorothy, if you'll move your mic over, and DT, if you'll move your mic, and Reverend, if you'll move your mic over, I think we'll have it.
You want mono or you want stereo? I think one of the things that I'm trying to get to is kind of like matrix type thing, you know, for Dr. Becker or Mr. Early to be able to make sound decision based on the physician group. We are in our 6 or 7 years now, right?
Yep.
So what we're trying to get to is give them the flavor of what kind, because we have all kind of doctors. We have all type of doctor different ages where they about to retire. We need to train people and all sort of things. And then we have teaching facility. So what I'm trying to get to is two things are very important for us going forward. Is looking at the quality factor and the profitability factor, right? Then you can determine. Yes. So because, once, you look at FTE, you look at volume, you look at compensation, incentive, on-call, managing the mid-level provider and all that stuff. The other side of it is that the Medicare, Medicaid, acceptance rate, age of the physician and all that stuff that drive into our recruiting effort and all that stuff. At the end of the day, I want to sit there and say, we have 4 types of doctor, right? These are the low profitability type of doctor that are training. They're still in training. And then this is the super doctor, right? The best doctor, other hospital want them, high compensation demand, maintain super status, because one can help uplift the rest of them. And then the other side of it, you're gonna have the killer doctor, and then you have a cash cow doctor. Which one do they belong that, so that you can see in their mind, how do you motivate, how do you pull them up, how do they help one another, so that we can have all that diversity that we need to pull the system. Because if we're not careful, at the end of the day, we still a county hospital. That heart still have to be there, and the passion still have to be there, not just all about money. And those are something that's important. If we walk away from that a little bit, we'll have a different result from it. So I think what's hampering us is that we just recruit doctors, but we don't categorize and sit and know what they are.
What bucket they're in.
What bucket they fit in. And that's a decision-making process for recruiting, maintaining, and then also help recruit the future doctor also as well. What do we need in that to fill that spot that we need, and make it more meaningful for them also as well. And how do we get there is what's needed, because we are 6 years into it. And I agree on the investment, but some investment you have to make. I never said it's a loss, it's an investment. And if it's always going to be a negative, which is good, because primary care physicians, you're supposed to lose money. Because at the end of the day, we're sitting here, cost containment, the money stay up here at the system level. We never be able to make that connection. And it's very hard to justify that, saying that we lose money all the time. It's not losing money. It's demoting. It's not right to send the communities that we have to lose money, because HFMA tell us that we're going to lose money. And MGMA telling us that no, it's an investment that we're making in certain things. But we have to be able to reach out and say, that's the impact that we're doing for the community. And if we don't have that, we're not going to survive when we stand up the new system. The new hospital is going to cost more, and then we're going to have to sacrifice service and care for the patient to pay for that. So
Right.
that's kind of.
Please go right ahead.
Hey, first of all, totally appreciate your comments, and by the way, good afternoon. It's a pleasure to be here. Relevant to what you just described, I think it's going to be important for our entire physician base.
Brian, let me interrupt you. Can you take off your mask?
Sure.
Please?
Now we can recognize you when we outside of this hospital.
So I'll note that. The same goes for me. I think it will be important as we look at our physician and non-physician clinician workforce over time to align it first and most importantly with the strategic objectives that we have, and to actually think about the qualities and the talent needed to implement some of what you're going to hear about care models. Because to your earlier comments, the type of physician who's successful managing a panel of 2,200 patients in Medicare Advantage is very different than the type of physician who's successful managing a panel of 1,000 but teaching 4 residents successfully to do that. Second, I think if we align to the strategic objectives, we're also going to be reinforcing what we believe, what Robert and Lauren and Karen and team have created to be successful organizationally and still consistent with who we are. And then finally, third, and I will use the example because you noted the cash cow, there are other safety net
organizations throughout the country that have, as they've developed their new physician workforce, made determinations of where key areas are that they're going to be the best at. The prime example historically is Harborview in Seattle, which is a massive safety net hospital and had a set of back surgeons who were the best in the Seattle area. That's a decision that, from a workforce standpoint, from a capability standpoint, and from a resource standpoint, we're going to have to consider and think about the implications there. And those implications aren't just who's coming in, it's how do we manage and effectively work them with the other physicians who, when you do something like that, get differential types of attention. But it's an apt point and one we will consider to make certain it aligns ultimately with where we're going strategically and how we reinforce the right types of physicians for who we are in the future, as opposed to reinforcing always the physicians who have been great, but may have been only the physicians that were successful back when I was starting my training in this type of environment.
I'm just more like you said, we want to have the best of everything. It's a lot easier to change profitability and quality. That's why if we're going to go that route, how do we sprint forward so that we don't lose the quality side of it if we have
Absolutely.
to sacrifice certain things? So.
I would like to make one observation relative to adhering to these strategic objectives. And we have always looked at strategies at our level, obviously, from a policy perspective, in a very, very broad and generic way. That sometimes indicates that we don't have key performance indicators in areas that we probably should have key performance indicators in. I hope that with your leadership and guidance, you don't feel that you have to be limited to very generic strategic objectives and initiatives. I hope that you grab the tiger by the tail and say, we need to do this, 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 and this. And I hope they fit our strategic objectives, but I don't care. I mean, I want to see the change. I want to see the things happen that need to happen. And if we need to come back and alter our strategic objectives, then by all means, bring to us recommendations to alter those strategic objectives, but by no means feel limited by them in their sort of generic application. Does that make sense?
Absolutely, absolutely.
And Trina,
I think that sort of speaks where probably most of us are coming from.
yeah, I was going to say, I agree wholeheartedly. I hope today is kind of a new day for Acclaim, because if you read the summary of primary issues, this is not a glowing report after 6 or 7 years of operation. Like, Acclaim governance is adversely affected by lack of transparency in decisions and information. I mean, that's day one, base one stuff. My question is, we're projecting $41 million loss or investment. Is that taking into consideration fixing some of these primary issues? Because some of these are going to take money to do.
So the current numbers that we've shared are just, they're
That's
either
just
historical,
operations.
yeah, operational 19, 20, and projected 21.
Okay.
So not factoring any improvements. What we are doing along the way is, and again, as you look at these, we continue to cascade these to very tactical levels, and we will assign dollars where there are dollars, where there's opportunity. You're absolutely correct. Some of the, again, it's not just, cutting your way to success. This is about growth and how you develop programs and again, I'll repeat this several times. The alignment piece cannot be understated, because again, it is about, going up and down the chain and making sure that, again, programs aren't developed over here that are disconnected over here. And I think that's the ultimate way that, Dr. Becker's going to have huge opportunities to, work with the systems in both to say, here's how we grow. We grow smart. We can't do everything at once. I mean, if you could, that'd be great, but that's why we put this into a prioritization matrix and say most impact, and that can be financial or it can be community.
Sure.
And you're going to have the opportunity to choose those things and say, we have to go after this first.
Okay. Well, I mean, I guess my point is, I don't want to throw good money after bad, right?
Right.
But, and I'll probably make some comments later because I can't be here next week. But I think that what we have seen this year is that there are some areas that need more investment. And as we're talking about budget, we should make sure that we are investing properly in those areas. And this is certainly one of them. So, thank you.
I think as staff, we very much welcome you all doing that. If staff's going to make a recommendation, then we're going to look to the board for guidance to say, you know what, we think we should put 15% more here. We think we should put 10% more here. Not only do we welcome that, and I think that makes for a better situation. We're going to see one angle of it as staff. You all as a board directing the policy of this entire organization is going to see it in a potentially different way. The other thing that I think the burden upon Dr. Becker's shoulders, and the one that Mr. York and his consulting team are going to have, is taking a physician group that was splintered in 19 different physician groups. And you know this all too well, Chuck, in that you had this strange evolution of JPS's physician group. You had one group, you had an administration that came in and said, I'm not going to have one group, I'm going to split y'all up in 19 different groups. And now we've come back to, in essence, one group. That's not an ordinary process in about a 13, 14-year period of time. So the other challenge with it is you got a physician group, be it better or worse, depending on one's perspective. When we put the acclaim group together, you inherited 200 doctors from UNT that said, we stop our clinic process. So it was a different process, and I think, to me, we're at an incredible level of we can really make a claim work or fall backwards and continue this downward spiral, or at least a challenge. So I think we're really in, not to be overly optimistic, but I think we're in a really good place to say, okay, we've had 6 years of sort of stops and starts and movements, but you have a physician group that Jay has discovered that at least has a level of direction and alignment, but can you codify that? Can you put it into place? And I think, and not to put all the burden on you, obviously, it's us as staff, it's us as leadership, it's the board, but I think we have things in a hopeful, better place.
Can we make, I mean, take this same slide and reevaluate it in 6 months? And whether we do that in the governance committee or whatever, to see that some of these things are so basic, like they shouldn't be there. And I don't want it to slip by in 6 months and we've done more money or we've done whatever. I want an actual, and it doesn't have to be a fancy new presentation. Just give us the slide and tell us what's fixed and what hasn't been.
You bet. You bet.
Yeah, I was going to mention Trent and kind of grabbed it early. Actually, when you look at this whole process, they must have turned my mic up thinking that I was you. But when you go back and look at the process, it kind of started all the way back when Trent was chair, and it went from Trent to me. I mean, when we were looking at how to deal with the issue that you just mentioned, the 19 and the different groups. So when you look at this process, it's really a new baby. And we're now, because I was going to ask Robert, but he responded to that, is how he felt, where are we now? Because I can remember him echoing those same words about the physician groups and all of that and all the issues, and Dorothy and I forget who else, took the trips out of state to look at programs to see how. So even though we might see some issues and problems need to correct, but I think we're a long way from where we were when you go back and look at it. So, and I agree with Roger that, as we look at those areas and we go at it and fix it and deal with it, I just hope one day we can see the report that we're not in a deficit with a claim. That's
So you can have the best plan you want under do you can identify, do we have the right person in the right seat to carry? Otherwise, it's just a check mark. Jay say this, check, 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 and then, but if they don't have the depth of that transform from that piece of paper and the checklist to the working session and how to execute short-term and long-term, we're back to here 6 years from now.
Right. So,
You need to hit that DT button.
Yeah.
That's the button I hit.
This is a historic meeting, yeah. DT's giving microphone advice. We've come a long way.
Well, I disagree, Charlie. Looking at this report, I know what you're talking about. It was just a good segue. There seemed to be a lot of opportunity for improvement right here, which concerns me a bit since we've been doing this for a while. And as Roger kind of pointed out, a lot of this is just basic. It should be 101, not 401. I also need a bit of a help, and I've told everybody before, I'm not a finance person, but when you say loss, does that mean business they lost, or is it their budget position? You're talking about a $41 million loss. Define that for me.
so, you want me to take that? Is that a?
Well, we're all looking at each other.
Yeah.
And no one's trying to waffle on that answer. But to Jay's point earlier and others, you're not going to get a physician group to make money because what we have to do to pay the physicians to see patients that are not paying patients. So if we decided, and Jay, you can help me with this, if we decided we weren't going to have a claim and we were going to hire all the doctors in a different manner, it would be a direct contract with physicians. You would see at even greater cost. So that's why I think Jay and DT were talking about the term investment. And it's not a 40, I mean, the network, and Sharon can tell you, the network absorbs that cost so that we can have that delivery of care. Am I helping you to see that?
No, let me do it a little bit differently. In the business world, you're either over budget or under budget. When you talk about a loss, that's a loss of business in my mind. And I don't think that's what we're trying to say here, and that's why I'm confused.
So with a typical physician group, and again, let's take it out of the JPS world for a minute, because there are factors here such as payer mix and things like that. In a normal, payer mix, your expenses are gonna be greater than your revenues. So that equates to the loss. Now, the reason we refer to it as an investment is because it's only one piece of the puzzle. And so take surgery, and again, I know Dr. Weber can speak to this too, but if you think about a surgeon in an employed group, most of the time, even if it's run extremely efficiently, there's a portion of that revenue that comes into the physician group. The fact that that surgeon does surgeries in a hospital, the larger proportion of that revenue resides on that side. And so you're looking at one piece of the puzzle.
So if I was to sum this up, and from my understanding, the 41 million is they were over budget. Go ahead, somebody else try and help me out. mothership, the overall banks I've got has to pick up that cost. And I think that's kind of how I've always looked at it. For God's sake, all the experts tell. But it's not loss of, you come from the revenue world. Did we just let $41 million worth of revenue off? I don't think that's what it is. We pick it up within the consolidated
We do.
in the district, and it's, I hate to use the word loss either. But as long as this board believes a claim is a important factor to the overall health delivery in this county, the mothership's picking up a lot of this cost.
Brian, help,
That's my thought.
help. No, yeah, but I think, I think that Dr. Becker can help because he's seen other systems. He's run 2 of them. And Zim, I know where you're coming from. I'm desperately trying hard to think of in the aeronautics world or something that can relate, but it's not going to relate because they're 2 totally different businesses. So, Brian, go ahead.
It is a valid point, and if you look, and let me frame this as 3 different things. First of all, there are physician groups that are single specialty physician groups that live and exist, and one question you may have is, well, how are they doing that in the outside world if we're seeing this? Many physician groups have done several things to optimize different and diffuse revenue streams in addition to practice revenue. That's number one. So I may own a building. I may lease that to somebody else. I may own part of an imaging center. I may own part of a laboratory. Things that get scrutiny from the government, but nonetheless are alternative revenue streams in addition to practice revenue. Second, there are large multi-specialty groups such as Acclaim, and to the point noted earlier, you are dependent within a large multi-specialty group on certain types of professional revenue, and you also acknowledge if you're working within a system, and one of the goals I hope we achieve is a level of systemness. We are the network. We are part of what is, I hope, and it has been explained to me, a really important set of care entities. In that context, some of those physicians do not have access to those alternative revenue streams, and therefore they are dependent on another entity to either cross-subsidize or actually to provide direct support. And in this context, the third bucket I would talk about is it is not infrequent, even at some of the most established and well-known places of healthcare in the country, that physician groups continue with this type of, and I'm going to call it a constant deficit budget, where they are invested in because that entity does not want to lose certain things. And it is viewed also at the same time as that physician group, and this is where I get to systemness, makes the necessary changes and develops its talent to advance the overall delivery system or health system. And my perception as an outsider walking in, and now as an insider for 4.5 days, is that one, we do need to be better managing who we are within Acclaim financially. I have no qualms about acknowledging that today, even from my high-level overview in a very brief period of time. Number two, I will make certainly efforts to present Robert and Karen and Sharon and the rest of the team. Here's how we think it's important to make certain we're delivering, and here's the types of investment we need. And that's where it gets to that third bucket and how we think of this. Hopefully that's adds a little extra detail.
Yeah, well, Karen would testify that we've gone around this several times, Sharon, and my problem is it's growing in number. And I would think at some point we ought to have enough smarts to bring it back down. And what I don't see here that helps me understand this more, we talk about COVID. What part of this 41 million was somehow tied to COVID and then we could get a baseline for whether we're really improving or not, because COVID, everybody recognizes, was a really unique situation for us all.
Challenge them, treat them more like a better word for it, like a regular business. That would be our R&D. It's kind of hard to justify revenue for R&D type thing. So what you may want to look at, that's why I want to look at from business line, and then each line, book a business first, like which one is commercial, which one's Medicare, which one is JPS connection. And then within that, we look at the line of business. Then we can put P&L against that line of business to look at it and say, let's say if surgery, right? Then, there's revenue for the surgeon, but then there's also, you have to have surgical assistance behind that. You have to have a bunch of other people driving that. So where do we make, we have to cost contain them. So that's why I want to look at the matrix rather than anything else to see if we're not making money and let's try to improve efficiency. If we can't, then there's maybe a contracting issue with the payer or is it with the physician, and how do we reward correctly? I think those are to be developed and enhanced. That way you can roll up to an enterprise level. You can see all that stuff and where they fall. So from a, for COVID, right? Everybody say, COVID, we're going to lose money. Well, we're going to lose money on the commercial side, but I'm not sure from the JPS connection side we're losing money. Because overutilization that we had before, now we're underutilization. But if you're holding on the money and you're not utilizing, then you're actually making money. So, or you maintain it for investment for other days. So, but none of us can answer any of that questions. And to be fair, because one runaway train wreck killed the whole budget also as well. And so, but by the time we get done, you'll be 5 days into it.
Overview of where, we're in the ballpark. Prior to COVID, a claim was running and projecting about a $25 million loss, and now we're at around a $40 million loss. Now, we have added some physicians, and that's just looking at their income statement, but you've got to take that a claim and then add it to, let's say, the $100 million that the medical center is earning. And that's why those consolidated financials are so important. And when I look at balancing the budget, I do have to look at the cash flow of the system. And we'll go over that a little bit more during the budget presentation. But I think if I had to give you a quick answer, most of those additional costs that a claim generated during COVID was because of the shutdown from the outpatient side. And we elected to hold our physician network whole to make sure that when the recovery did happen, that we had providers to care for the patient. And so I don't know if that was a little bit more direct answer to your question.
I think everybody's giving me a piece of the answer. My problem is still, I've come from a business background, and so when I see something on one of your charts that says it's green and it's above the line, I'm going, that doesn't make sense to me. I'm still wrapping my head around that. But the thing that, I get back to is we ought to be getting at least a little bit smarter and driving those numbers down.
Yes.
And I don't see that trend right now.
And so this presentation from the Guidehouse study is really preliminary. The second presentation is going to give us some options and a lot more information about the drivers of those losses. And, Roger, you're right. There's going to be some things where we need to put more money into. But I think with this study, we're also going to identify quite a few efficiencies that we can achieve. So we may be able to get back to at least where we were pre-COVID, and then make sure that we're seeing more patients at the same time.
Just alone in the compensation plan and trying to make sure that we have the most equitable compensation plan, because to Sharon's point, we did keep those physicians whole. And one could argue that, but in a post-COVID recovery, we still have all the physicians we had here. Now the question is, if we add more physicians, did we add the right ones, to DT's point? And that's where I think we got to dig deep. And that's where I think we need to look at efficiencies.
I think part of the challenge that I have is that we're looking at billable amount as the revenue for a claim, when majority of them are JPS connection. And that shouldn't be it, because we don't have the revenue, but that doesn't mean that we didn't spend, right? So part of the things, how do we bridge the gap and look at it from that perspective instead of how much we actually, as a system itself, we spent during COVID time. And it could be because we have compensation for the physician, fair, unfair. That is the compensation we have. The only opening that we have going forward is when we renegotiate the contract, we align it correctly. But a contract is a contract. We can't go back on our word. So, but understanding that, and if there's a minimal performance and we don't have volume of the physician coming in and we still have to maintain all that stuff, then we know if we have to, under contract, or for the county, we have to have 24/7 coverage and the light have to be on and all that stuff, then so be it. So we know where it is. But I think the revenue is an old methodology that may needs to go away so that we can see it the way it should be. We are an ACO or whatever, our own TPA for that population. And we can't be looking at the revenue. We got to be looking at the spend on that side. And where do we curve? Because you don't have the revenue because 48% of the cost is hospitalization. You don't have hospitalization during that time, so you don't have the revenue. But that doesn't mean we didn't. That's a benefit from it, but so I guess Jay might have to come up with a formula for us to bridge that gap, because it's very difficult to look at from that standpoint.
I would say that as long as I've been on the board and we did budget retreat, this is the longest we spent talking about any of our physician group, which is, I believe, a great thing, because we have said it's been here, it's been there, but it's kind of tell us what you're doing, and this is what it is. So I think this is great that we are getting into it, making sure that those alignments. The one thing that I will add is we are responsible for JPS connection, and we should know how we're spending it, and that should be looked at, and that cost should be factored into that. And I think that will remove a lot of this is why we are losing, because I don't think we really are. But I think that having the information will give you the facts that says, Zim, this is how much we are paying to take care of JPS connection. I mean, just like any other patient coming into the hospital, you do a bill on them, you look at it, and you come back. The same way Medicare, Blue Cross, they look at their billing, we ought to be looking at our stuff for JPS connection.
And Roger, I apologize that we didn't talk to you in advance, because I know you've asked some good questions, and so has Zim, and I know how much you hate not being able to be at next week's meeting. So we're going to have our meeting where you are next week. So everybody's going to be where you are. It's going to work out just fine.
We're going to be in Las Vegas, so. Let's go.
Well, for the purposes of live stream, the fact,
Mr. Chairman, I make a motion that we accept Roger's proposal.
the fact that this meeting is live streamed, I hope everybody listening knows that I was joking, and this is not going to be conducted in Vegas next week. We can't do that.
I'm going with Steve's recommendation and second it.
The last thing that might help you, Zim, to Dorothy's point, when you start looking at the cost of taking care of a patient, we're probably the only healthcare network, along with the other 9 public hospitals in Texas, that would do well if we had fewer and fewer patients every month. If you look at an ordinary business model, when an individual comes in to our not-for-profit and private friends, that's going to be a model by which they want to enhance patients coming in their door. We're the reverse of that. We're an upside-down pyramid, because if we had a reduction, quite frankly, of the connection population by 50% or 60%, it would be a savings to the organization, and that's a totally different model than what you're going to see in any other place. So I'm probably the only CEO in town other than maybe Dallas saying if we had less patients, that would be better. If we put more patients in a different type setting and got them another type of care and less were actually here, it would be an advantage. It's a totally different model. Sure.
Recruiting and all that stuff, we're gonna have to sacrifice quality and all that stuff.
Right.
So it's a lot more.
It is.
What we're trying to get to, Jim, is understanding so that we can see how many people that we have in our population that we manage, that we attribute it to the physician, which one have primary care, even if we have primary care, why they show up at the ED or the urgent care. If they show up urgent care instead of going to the primary care, do we have scheduling problem, or do we have a trust issue with that particular doctor that doesn't have a good bedside manner and they don't want to go there and they go to urgent care? So you guys can make that kind of decision making and retrain them, and then to see how much cost they have, right? If they keep the patient too long, not to a specialist, and then the rising risk go up, and then now we're facing with a lot more expenses by not taking care of them. So I think hopefully we'll get there.
Well, I'm certainly sorry to have produced such a discussion.
No, I agree with Dorothy. I think it's helpful, but Jay, you might want to start now with the bulk of your presentation.
I'll be
Can
happy
you go
to.
ahead
No.
and now get out of the preliminary stuff and start your presentation?
If I may make one, before you start, Jay, there's been a lot of talk about a claim as a baby, et cetera, et cetera. Brian will be about either the fourth CEO we've had of a claim. So we've had different styles of leadership over there. I don't think in its entirety we've ever had it looked at like Jay is looking at it. So I don't want people to sit back and say, the doctors aren't doing their thing, et cetera, et cetera. I think what I'm hearing from everybody is the physicians, et cetera, are a very valuable part of the group. They're not just an appendage, like an arm that hangs off the body of JPS, but that claim is an integral part of the whole network, and I think we agree to that. And I think Brian and Jay are bringing us a new level of knowledge and expertise that will allow a claim to keep growing. So I look at a claim as more like the teenager. And you guys are, one can be the mother, the other can be the father, I don't care, but I'm looking forward to what you've got.
Let's see how you handle that.
I always want to have some, I like controversy.
Oh, you're gonna get it.
That's okay. I'm ready for it.
Let me close the loop on two points that have been made. One is, and Dr. Weber, I think you teed this up nicely. We work across the country, obviously, a number of organizations. I've been involved with two recently that one is a sinking ship. They've had a lot of trouble, and we've been literally trying to save them. That is not this organization. We have another organization that is so dysfunctional, it's hard to figure out how to get them better. That is not this organization. So it is a maturity question. And again, I know that sounds a little bit overused or overly simplistic, but it truly is. The way this has come together and the way things have evolved, not very often do people take the time, and I call it zoom out. You don't really get out and have that 60,000 foot view to say, okay, we built this, but we built it in parts. Now let's kind of put it back together, and you'll see on one of the comp slides that we're going to show you, we always liken it to a collection of practices versus a group, and it's that group mentality, but as Dr. Becker will attest to, it becomes a systemness look. It's not just the group, it's how it plays into the system. And so that's a key piece. And then to your earlier comment about the basics on this, absolutely true. And sometimes it's a function of how it came together. And those can be easy fixes, but it also takes somebody willing to back up a little bit and say, let's just look at how we do things. And so, there are resources that go into this. Some of the things that we have talked to, the administrative leaders about, they've not disagreed with. they're open to this change. And I think that's a great mentality. So, again, if we can build on the simple things to get to the more complex things, it will push you forward. And again, you'll see the progress.
Thank you, Jay.
Thank you. Great discussion. So with that, I'm going to move to the next slide. And this is really starting to take all of this that we've talked about and saying, where does this go? So the first circle on this slide really talks about what I mentioned earlier, the internal piece. This is the operational improvement. This is what we've assessed. This is where we can fix things that, don't work today, make them better, and mature them. The second part becomes, how do you integrate that with strategy? So again, strategy becomes an easy term to use, but this organization has done a tremendous, this board has done a tremendous job, writing a new strategic plan that, again, I don't think we feel limited by. Certainly you made the point that Dr. Becker should not feel limited by, but it's a great framework. And so when we look at how the improvements can be made and where that growth can occur, it does give you a nice North Star. So again, you can keep moving that direction. So operations, strategy, when those things are developed, then it becomes, how do you start to operationalize this? How do you create the right work plans? How do you create the specifics around it? And all of those things then get evaluated at an organizational level to be financially sound, operationally sound, and then they feed into the budget. And so the relevance to this conversation all is there's a sequence to these events. And so, as I mentioned earlier, there's a lot of stuff to do. You won't be able to do it. And again, you won't be able to do it at once. And so it does become the prioritization, but it means you put things, in a prioritized way so that you know where you're going in the future. And I think that's a great opportunity to link all of this together. So I think as we transition out of sort of the operational and strategic piece of this, one thing we also wanted to bring, to your attention is as we're starting to ramp, down and close out the assessment piece and bring those findings forward, they're going to feed into this next phase of work looking at the comp model redesign. And this, again, is a great alignment opportunity. We don't ever look at compensation for the physicians in isolation. This has to be something that is tied not only up through the financial world and how the revenues are generated, but it's also overall alignment and engagement within the organization. And so one of the things you'll notice on here that we talk about the factors, what's driving comp redesign. You've got a number of unique factors, again, with the way the group was brought together, but, this move out of the, fee-for-service world, rarely have we seen many people outside of a few hubs, and Dr. Becker, I think, has experience with this too, but California is a very value-based world, take a lot of risk. Some of the systems in the Northeast do. The middle of the country, a little less so. And so you're not going to move out of fee-for-service completely right away, but as you start to step into this value-based care world, you've got to really think about the plans, how that evolves, how it ties to the payers. You can't do it in isolation. So that's a very big driver right now. And then, again, as we called out, there are financial reasons. There's transition to acquisition. Acquisition doesn't have to be new acquisition. It can be the simple fact that you brought a bunch of different groups together, and now you've got to integrate them better. And then focus on retention. I mean, the big piece here is that when you look at comp and how stable you want your workforce to be, to your point, DT, about the, the age of the physicians, you've really got to look at, over time, when will retirements occur? How do you replace, your workforce? What do you want to grow? And those are important factors. And then the point that I made earlier about this move to groupness and systemness, I mean, it's going to be an incredibly important factor. And so as we step through the pieces right now, we're in the process of engaging the physicians in this work. There is a steering committee, a comp committee that we are getting great engagement from. Almost, I would venture to say, better than I've ever seen. They're anxious for this and they want to be involved. And so as we step through, we are creating a foundation. What are the right comp parameters? What's the philosophy around comp? What are the things that need to be built into a comp plan? And in that sense, you're getting a very full picture about how we build this collaboratively.
Is succession built into your model?
the succession is not necessarily built into the comp model per se, but I would think as an overall comp plan, you've got to be thinking about things like, if you're a physician that's going to retire in 2 years, I don't want to hear that 6 months from when you're going to retire. I want to know 2 years out. And so, you know, when we look at those things, we don't want there to be any disincentive for you to start slowing down and making the transition. I want to have time to recruit. But again, this is a very strategic issue that, you know, the 4-day-in president will have to operationalize.
It's not always pleasant, but at times there has to be aggressive succession planning and moving certain positions to retirement.
Right.
Probably have held on.
Yes.
And I understand that, but you can't maintain an effective compensation model if you're not aggressively doing succession planning on both ends.
Right. And again, that is a very valid point. I think that, again, it goes back to, do we have the right physicians? And you have to define right. You know, how do you push that forward? I know Dr. Becker and I have had some discussion around this, so I just want to pause for a minute, see if there's anything to add there, because I know it's an important issue.
I would just follow up with one extra piece. It's been mentioned a ton. The first big rectangle here is value-based care. You're going to hear about it. And it goes to physician skills, how you manage patients, the comments about connection, and it goes to succession planning entirely. And the reason why I say it is when you start factoring in the fact that physicians, if we think about compensation redesign, we're going to have a component that's still taking care of people and still taking care of hopefully more people. We want to do that. But you are now going to be also examining at a physician level their quality of care, their ability to manage. I'm going to use a bit of lingo because you used it earlier, HCC scores. And we know how we're categorizing a patient and the amount of money that should be coming in for them next year. You are going to be thinking about a compensation plan as it evolves that is trying to build not just for catch up to today, but at least put some things in place that allows us to look forward. So.
Yeah, thank you. And a lot of flexibility built into that. And last point I'll make on this is when we say equitable, you know, clearly the first thought is equitable among physicians, so the people you're shoulder to shoulder with and across that type of thing, but it's also equitable to the organization. It's got to be, you know, built appropriately, and so that's a key factor in this. The last piece that we just wanted to share, and again, there's a lot of detail on this that I'll certainly be working with, you know, the Acclaim team and JPS on, but we wanted to set the bar for you in terms of expectations. And so if you look across the top of this slide, this is an aggressive timeline. I mean, it's aggressive, but it's reasonable. And the fact that we have allocated, you know, almost a year for this. Now, again, if you do the math on it, some of these steps overlap. So you can't just add the numbers and say, wait a minute, your math's wrong. We have really begun this kickoff phase right now, and so we've had the first meeting with the group, and what I expect to come out of this comp committee is future subgroups. So as we get more into detail, because some of the comp plans are going to have common factors, and some are going to start to be a little bit different if you think about primary care versus specialist, and how we cross-pollinate some of those to make sure there's an organizational view. But ultimately, we're going to walk through these steps of, you know, understanding the current basics now. We're going to develop that philosophy that I mentioned. We're going to spend about 3 months doing modeling. You know, we're going to be going, and again, it sounds like a long time, but we do this at an individual physician level, and we try to understand every nuance so that when we develop these plans, we know where the levers can shift. And ultimately, when that is decided upon and we move forward, we'll go through a shadow period where we can match comp to current payments. And one of the most important factors there is when you start to shift your priorities. So again, using the value-based as an example, if you design a model that's more heavy on quality metrics, and again, let's just assume that's aligned up and down the organization, you can't flip that switch in a day or a month. You have to give people time to adapt, and we have the ability through this engagement to actually build the infrastructure to support it too. So again, it comes back to some of those basics and looking at this operational structure to make sure that this will work and that you don't create disengagement as an unintended consequence.
Good question for you. When we look at compensation, physician compensation, we'll be looking at will you be able to give us, the real cost and then what they call a real value pricing analysis? Because there's additional value that physician bring in that we don't recognize when we just see black and white. And not just a profit and, red or black ink, right? Things like, clinical service hours, the on-call coverage services, the mid-level provider supervision services that they have to provide, and then other time value. And then you can look at that and then compliance risk. And then you look at all that stuff, then you come up with the adjusted relative value unit for them. Otherwise, we miss the whole thing. And then that would be, like those that are more experienced, we don't align interest correctly.
So I think from my perspective, yes. I mean, there's an element of this that, there's this cash piece, right? There's sort of the total cash compensation. You can throw benefits and things into that, what's the payout? But it doesn't paint the full picture of value. And so, that gets back into the conversation around if you have appropriately aligned compensation with all the right factors, then how does that deliver for the organization? And again, I don't think we need to go back through the financial piece, but those are all the drivers. And so I think that when you and we typically will break, all of this down into clinical comp and administrative comp and all of those things you mentioned, on call. So, we're pretty comprehensive in that approach, but ultimately, we're looking at it from, what's equitable, at a physician level and a specialist level, what's equitable to the organization, and then, the value driver across.
All the clinical input, and all that stuff that comes with it, right? Like a physician, what's the work RVU look like? How many days per week are they working, right? And then weeks per year that they're working, how many vacation days they're gonna have, annual clinic days that they're gonna have. And then you're gonna have clinic hours per day and then annual clinic hours and all that stuff. When you start looking at those things, then you can look at, what else are they doing with their spare time, right? What's administrative time, what's paid time off, what's annual non-clinic work effort that they have to do. Otherwise, when you go to them, they're gonna say, you missed this day, you missed that day. We lost all of that opportunity to be collaborating with them when you have that meaningful conversation for you to drive that workforce that you want. So those are, I can give you some of the cheat notes if you need it, but I think if we're gonna do that, let's collect them over time, because it's not something we can boil the ocean and fix things overnight.
Right.
I'm always a firm believer, you can't. It takes 9 months to make a baby. You can't 9 women to have a baby in 1 month. So let's gradually move toward that and fix it once and for all. Otherwise, we're gonna have another study next year.
Well, and I'll say that one of the things we'll want to work with Dr. Becker on, and we've asked the committee about, is what we call minimum work standards. So the things that you talk about, and again, don't look at comp solely as comp, look at it as how do you create a plan that, again, affects patient care? When I say minimum work standards, it does get into the level of, when are you in, what are your patient contact hours? When do you see patients and things like that? Because ultimately, it's got to drive that element.
From a philosophy standpoint, do you look beyond what we pay them? For instance, the impact that they do in the post-acute care, the impact they do with rehab and all that stuff. Because, sometimes we have to look at what we call the cost of home health and DME and all that stuff. And sometimes, those are some of the drivers that you see, recertification, all that stuff, and you say, this doctor refers so much to this, and they're all 5 or 6 recertification from home health or DME. You have to wonder, do you really refer that many, or you don't read the note, or you actually is a medical director or the consultation approach with that group? Then we need to bring in our compliance officer and say, there's a conflict of interest here that you didn't disclose. Things like that you can start fine-tuning the workforce and taking all the other non-distraction out of the way, because otherwise we're going to be beating on the doctor all the time. I don't want to beat on the doctor. I want to save waste and abuse.
DT, let me preempt that question, because I think there's a previous question to that. And I want to know if you, Jay, Dr. Becker, do you think that we have
me is a significant policy issue. Has the board provided adequate philosophy on compensation through the strategic plan? I don't think we have. I don't think we have at all.
That haven't been part of our conversation.
So when does that philosophy, as that philosophy is sort of put together and aggregated, is that not something that you're gonna need board input on to establish that philosophy? And is that built into your process and your timeline? How?
As we develop that?
Yeah,
Yeah, no, not at a board level, but that's certainly something we can bring back.
because see, I'm gonna rely on her. Because part of what we're trying to do philosophically with strategic plan is to make sure that we have, delegated correctly what our philosophies are when it comes to compensation. And we've identified what those are, because we made a conscious decision during COVID not to lay off physicians.
Correct.
We said, we're gonna keep everybody whole, that was a policy decision.
Right.
And I think we're gonna have more of those. I hope we are, and I think built into this process should be that input strategically.
Yeah, please.
I think it's absolutely essential. I think if you look at the arrows at the top of this slide, it's going to be incumbent on Jay and myself, and we will make certain it gets back on the agenda at the appropriate time. It's actually going to be in the middle of the develop comp philosophy piece to come back to you, and then make certain that we have at least, maybe not your final, but actually your direction when it comes to comp design and simulation in that arrow.
Good.
Yeah, the way we're going is totally different than the way we've done it in the past.
Yeah. But it needs
I am on board, believe me, with their approach.
And one other piece, again, let's be clear, when we think about how all of these other factors impact compensation, we never stray from fair market value and compliance issues. We don't put you in that position. We advise that going forward, the governance of compensation follows those things. And again, this is, critical to, why we involve finance, legal, everybody along the way. So we're all on the same page. I think one other point just to make about this, and Dr. Becker and I both pointed out sort of the top line steps in the process, the bottom arrow underneath all the detail. Physician communication, sort of bi-directional on this is going to be important. And then overall management of this, so that, again, as the process moves forward, the people that are in the rooms and on the committees help to champion, the right principles going forward. And that can reflect the board's, philosophies as well. But I think this does give us a new opportunity to really push this forward from an alignment engagement standpoint.
Anybody else, any questions for?
Is other board like this?
What'd you say?
No, great discussion from my perspective. I appreciate it.
The other interesting thing about Brian Becker is after 3.5 days of being here, he came to an executive retreat yesterday and he came back this morning. All of us waited in the parking lot to see if he was going to show up, and he did. Yeah, exactly. So, Jay, thank you very much. And Brian, thank you very much. Again, Brian spent a whole lot of time getting up to speed with Jay on that, and we are grateful and we are appreciative. If you would consider it, we were thinking about going into presentation number 2. What do y'all think? Joy and David, why don't y'all come on up and we'll go through this. What this is now going to focus on, and again, it is the beginnings of where we want to take you. This is not designed to be a detailed level of population health and where we're going. It is not designed to be who are we providing care to. It is a bigger picture, nor is it designed to look at one element of access, because if you make the mistake in this organization of looking at one element of access, you'll miss the entire process. So that is not to focus on one area, it's to focus on the general areas of it. So Joy, I think you're going to begin, and thank you very much.
Yeah, good afternoon. As Robert had mentioned, we're here to kind of talk about where you might see budgeted dollars for this year. And so with the great work that you all started in helping to direct our teams around a strategic plan, we know that as we look to develop care models of the future, that a critical core component and fundamental first for us is really taking a deep dive and holistically looking at access in the network. Access more than the call center, but really looking at the components across that continuum for the patient. So how the patients interact with us at the various entry points, whether that's the emergency department, whether they're coming for lab or pharmacy, looking at those workflows and work streams across that base, as well as eligibility and enrollment, and how patients interact and interface with us, whether through even internal referral patterns and external entities that may refer patients into our network. So it's really taking an opportunity to look at access as a whole, as a team together, in partnership. And definitely David's going to speak to a lot of the drivers that are going to help us to be successful as we look to optimize access to meet that needs, to create that firm foundation for our patients, so that we can improve that patient experience, as well as what you saw Dr. Becker and Jay speak to, is to help create that success for some of those different potential plans that we go down with value-based care models. The supporting areas of network access that we will definitely be working with in our teams is assessing communications. I won't steal David's thunder. I'll let him talk about the technology, but definitely getting back to establishing some KPIs and metrics to measure how we are doing around access for the patient. Taking groups to look at both clinical and business workflows that impact access for our patients, so that we can look to gain efficiencies, reduce waste. And again, it's all about the patient in the center and creating a great customer and patient service for them, which would ultimately also be of great value to our physicians, to our providers, and to our team members. And so that is a lot of that work that you're going to see in the budget. The items that are starred really indicate where those dollars are attributed. So you see one around the patient call centers, because we do see that there is value for us to potentially bring in some consulting work to really assess the current capabilities, the infrastructure, and the competencies as it's related to our call centers, really, and really to bring that together and walk alongside of us in that recommendation, so they really know who we are, but also can help to leverage those best practices, those national benchmarks and standards, and give some advice to us to help us to take that in a final and right direction. We also have dollars around technology that we know is an opportunity for optimization, and that being a great backbone for what we need to lift around access. And then business workflows. There are dollars associated there for as we look to map out these different workflows and work with our teams to understand what those needs are for those positions that would support enhanced workflows for revenue cycle, referrals, and authorizations. That is definitely where we have targeted and have identified opportunities that exist today for us to improve. And so this is a partnership, and I know that David's going to speak a little bit to some of those budgeted asks that might be directed around technology, but I'm also happy to take any questions too.
You realize there's always money around technology.
Yes, that's why I brought David up here to bring him up. But I guess I'll allow David to go, and then we're happy to answer any questions too.
I think one of the reasons why it was really powerful when Robert and Lauren and Dr. Duncan put together this presentation is many times you see me come and do budget asks, or to the finance committee, but let's be clear, there's a reason why we do it, right? Or Joy comes up with a contract, but there's a lot of synergies that happen way in front of the times we come to you guys and put those asks together. There's a lot of workflows, there's a lot of team meetings, there's a lot of dynamics that happen. And so when we started looking at care models of the future and some of the technology asks, that's why this makes sense for us to really be presenting this together. So you can understand that IT is always working with operations. Operations always working with IT. We are, even though we are two different people, we're always working for one purpose, and that's for the patient at the end of the day. So the things that Joy was just talking about, we broke up kind of the technology asks and the data asks into basically 5 different components, right? The first component, obviously having the patient at the center of everything we do, but there's lots of things that we can be doing for our patients and our Access Resource Centers, and I'll talk a little bit about that here in just a second. But we're also going to be asking in the budget things about interoperability and Internet of Things and infrastructure and cybersecurity, analytics, as well as digital capabilities moving forward. And those are very important things to understand, that some of the asks that we have sometimes are for staff or for infrastructure. Some of the things we're going to be asking for is, how do we deal with the patient? How does a patient access care? And it could be that we stay with the traditional model that we've been doing today, where we have all of these call centers that are just taking these independent calls from patients. But we know that that's a broken system. We know that there's some ways that we can be doing that better, either through education of what phone numbers to call, centralizing phone numbers, or developing some new technologies that are out there that we could then do what maybe banking has been doing with call centers for many, many years, where you think you're talking to a live agent, but you're not talking to a live agent. And unless you press 0 17 times with the right cadence, you're never going to talk to a live agent, because they can solve 80 to 90% of those problems before you even get to that live agent. Joy and I are going to be working with our teams to see what the opportunity for our patient base is going to be, with language support, with education support, and all those things that go into it, to see, are there things that we can be doing with technology on the front of that call that maybe can deal with pharmaceutical refills, maybe paying their bill, maybe just getting a reminder when their appointment is, all of those things when we're dealing with access. So we didn't call out specifically in this presentation all the things that.
I'm sorry.
Go ahead,
You make
go
a
for it.
great point, and
Yeah.
I know your philosophy is this, but I want to say it just so it's said
Yeah.
out loud. When you're talking about access and some of those automated phone, systems and all that, which I fully embrace, but our priority needs to always be the convenience and access more than savings.
Yeah, absolutely.
And efficiency, right? I mean,
Yep.
I'd rather spend more and have the patient get where they need to go without pulling their hair out, or throwing the phone against the wall, than to save $100.
Oh, we couldn't agree with you more on that. And when we were looking at this, the first thought we had was, you know what, maybe it's just our antiquated telephone system that we have out there that is just not doing what we need. So what's the cost to just get rid of that and move forward with something different? But there are other aspects that are doing it. And what we're doing what Joy was talking about is, we've got to map the entire patient journey out. How are those patients willing, because we learned a ton during COVID, we had assumed, and bad assumption on our part, that our patients were not technology focused, right? We'd had that assumption for the first 5, 6, 7 years that I was here. And during COVID, we found out that our patients really do like telehealth, and they like doing e-visits, and they like embracing that part of healthcare. And we had to flip on a dime, just change on a dime, and put together some care models for that. Now, as we look at access, we've got to be able to say, we're probably going to assume the exact opposite, that our patients do enjoy technology and they can access care through that. So we're probably not going to be sparing a lot of expenses to update that side of things. Is it my chart that needs to be expanded so that we can deal with patients that way? Is it more virtual visits? Is it a better telecommunication experience that they can have when they're calling in? Do we need to consolidate all these call centers into one environment, even though maybe virtually put out? But there's a ton of work that we need to now do when we map this journey as a patient on how they access care at JPS.
And I do want to say that this all begins with the patient.
Yep, absolutely.
What Robert spoke to and Lauren spoke to is patient advisory committees not making assumptions about what our patients want and how they want that, but also incorporating that feedback as we say, let's talk about that workflow and that stream of how you access our services, and what is this going to do for you as the patient so that we make this a better experience for you. And that also we are accountable back in that effort around measuring whether we're meeting that need or not. Because that's why we're here. I mean, that's why we're here. And so we called this out because that budget for this year is high prioritization around this access, around assessments. We're in a new world, and we now need to move forward in this new world and optimize off of what we've learned from this last year, and that's what we're dedicated to doing in this next year.
David, do you have a role in revenue diversification?
Does David Mendenhall and the CTO? Yes.
Trent, I'm sorry.
My question was whether or not IT, relative to access and improvement of care, have a role in revenue diversification.
I think all of us do, and if there are opportunities, there are a lot of hungry technology companies that are sitting out there, right? We could probably put a dartboard up, and any of us could throw a dart at it at the top 5 that are out there that could help us get there. But we know, and we've found this, and you guys, and I don't mean this to sound like an absolute compliment to this board, but it really is. Yeah, he does it all the time.
But if you want to say it,
But I'll say
go
it.
ahead.
Here we go. You guys, since I've been here, have pushed us really hard to make sure that our vendors are diverse and make sure that we're working with vendors that are local to the economy, right? And we've taken that personally, right? We try to find those vendors that are hungry for our business that can make the biggest dollar of impact for not just JPS, but also for the community. And there are several organizations that I think if we went after Avaya, if we went after some of those other places, we may just end up with another telephone system, right? But if we deal with local vendors that may have an opportunity to maybe do some co-development with us, maybe help us with some of those things, there might be some opportunity for diverse revenue streams, not today, but maybe in the future.
The other plus that you have, Trent, is you didn't see, but Mark Hallman's neck was on ball bearings sitting on the back row, because part of the role that I think it was smart to bring a chief innovation officer in is Mark looks at those opportunities, and Mark is going to go to David and say, I know of a company, I have a company, and they need an IT element to it, and JPS might do this. Mark can do that with Joy, Mark can do that with Karen, with me, and I think that will be a real enabler to doing a lot more diversification through IT and others.
Yeah, I think there's some incredible opportunities there.
I think so too.
I spent the last 2 days with a couple of healthcare CEOs, and the amount of data that's available that we can harvest to simply even improve our collection percentage or our patient base. Just take the number of people that leave the ED that never come back, that are actually commercial payers that never get in contact.
Yep.
And I'm thinking, like, part of this is data, or part of this is harvesting that data and being able to repurpose it and inject it into our system from the standpoint of not just making sure they come back for a second appointment, but what have we done to harvest that patient into the JPS system? And I think there's a lot of opportunities there. It can't happen without very, very innovative data intelligence that I think we got to adopt.
I think that you go and look at the data that's out there. Something you mentioned earlier, David, about you didn't calculate how computer or technology savvy community is. But if you look at why individuals have not gotten the vaccine, I think you'll find that it mirrors the knowledge they have in the whole technology area. I think that they're aligned together. The school district blew it when they went virtual and didn't look at the attitude of the persons who had to go virtual. And now they're trying to catch up. And so I think it's key, something Steve mentioned, we can be so virtual savvy, so technology savvy, but there is a core group of individuals in the community that have gone underground because they don't want to address that area. I can't give you the answer to how to get them from being underground. I'll give you one example of, there's this pastor at this church in Fort Worth that just swore up and down they could not go streaming. It wouldn't work. And he found out that it has been a major plus because he went streaming. His name is Ralph Emerson.
And Reverend Emerson, and you,
Encourage people to go to the website and listen to his and watch his program, which I've done that.
and Reverend Emerson, I think, if correct, you have about 200 people that attend your Bible study via streaming. Isn't that correct?
Right.
Well, I just want to emphasize what Trent was talking about with the diversification of streams. Anecdotally, and I won't name churches, but a local church came up with a way to identify parents and kids and has now licensed that to churches all over the world, and they get a piece of it. So I like that thought and where we could go with that.
There we go, David.
Yeah. On the top circle there, we have, Internet of Things and cybersecurity and all that stuff. Can you give us a little bit of what's in your mind, the short-term, long-term on that side of it? And then are you incorporating EDR and all that stuff into it?
So tell me which one because there are three independent things in that circle. There's infrastructure, there's IoT and security, and cybersecurity. Which one, we can hit on all three, or we can hit on one of the three?
IoT and cyber is infrastructure. We have conversations.
No, we have all that all the time. So Internet of Things, and so we just put IoT on that slide, is basically anything that can collect data for just a simple option, whether you're wearing a smartwatch, a Fitbit, or you're doing a pulse oximeter at a bedside, anything that can potentially create data is what we call Internet of Things. We have been working really diligently this last 2 years. We've purchased smart beds, right, throughout the hospitals that have beacons and Wi-Fi connectors, so we know where those beds are. We know maybe eventually if there's a pressure ulcer that might be coming up on that patient because that patient hasn't moved, or a fall risk to that patient because we've determined on the intake of that patient that they are a fall risk for whatever reason, and now we're seeing movement within that mattress, right? Those are very simplistic things when we talk about Internet of Things on what the data is doing. Part of the issue that we have with all of the data collection that's coming through, and I'll talk more about just the data lakes and all the data warehousing that can be done around this in a second, but is making sure that all that data is secure and it's validated. And that's a really tough thing to do. We have more vendors coming into this organization on a daily basis that they just want to put their beaconing systems on our network and they just want to say no, or they just want to say yes. My role in that is just to say no, to be quite honest with you. Our 3 rules of own it, seek joy, don't be a jerk. Man, it's really tough to not be a jerk to vendors that want to come in every day. It's really tough. But we hold a very firm line on that, and they have to meet our data standards, they have to meet our data security, they have to meet our firewall standards every day, and if they don't get on our network, and we make no apologies to that, right? So we're investing heavily, again, in cybersecurity for this. We're also looking at the IoT because there's the remote patient monitoring aspect that we are now in the middle of with our post-acute COVID patients that are in their homes and they're getting that oxygen support, and our case managers are calling them 3 times a day to make sure how they're doing with that oxygen intake. But we can be doing that automatically through IoT. We can be doing that through remote patient monitoring and just maybe calling them once a day just to check in, make sure that technology is working, or we're getting those streams of data consistently through our case managers.
So what's the vendor you're dealing with? Are they more doing their own EDR, or you guys doing that yourself?
We're doing it ourselves. We're doing it ourselves. No, not nearly.
That's why scale is there when I look at the IoT and all that stuff.
Yeah, we're not doing nearly enough around it right now, and that's something that as we venture into this, it's a slow churn because, and that's where I was going to get to with the data that's coming out of these things. What we have to be very careful about is making sure we're collecting the data on things that are actually going to have an outcome for a patient, right? And with Fitbits and smartwatches and Apple Watches and so on and so forth, the amount of data that we could be collecting, and there's been plenty of healthcare systems across, actually even DFW, right? THR was one of the first ones to co-develop the Apple Health Kit, and they're still getting revenue off of that. But the amount of data that's coming through the health kit really doesn't help the patient, right? There's nothing actionable that comes off of it if all of a sudden your heart rate jumps to 170 beats per minute. Well, does that mean a physician needs to call you right now, or does it mean your grandson just got a hold of your Apple Watch and is running through the yard, right? Those are types of things that are, yeah, it's a quality aspect of data at that particular point in time. And when we look at the mountains of data that we're collecting right now, analyzing that and putting it into a delivery model is what we're going to be capturing and doing this next year. We're really good at collecting data. We're really good at delivering data. What we're not good at JPS is analyzing that data to make sure we can understand it and put it into making better risk stratifications or whatever models you want to do. We're not good at that. And this next year, we're going to be.
The goal is to replace Alexa with Ask David.
No, you ask David anything in a surgical perspective, you're going to fail very quickly. Very quickly.
Thank you all for that report.
Yep, thank you. Thank you.
As I mentioned at the beginning of the presentation, we saved Dr. Duncan and the aspects of employees last because not only do we want Karen to be last, but the more important thing is we want you all, and you all know this, you can't accomplish anything unless we have engaged employees, unless we have employees that we're retaining in this organization. And that doesn't mean your executives, it doesn't mean your mid-management, it means everybody that walks into any facility at JPS that's employed here. Those people making all levels of salaries have to be addressed in this organization. And so Dr. Duncan is going to speak to some of the things that we need to be doing in the future to deal with our employees in a major way, particularly in the post-COVID world. That is a significant change for us and American Airlines and Marriott Industries and the banking industry. I know that all of you are facing circumstances that are totally different. Charlie, I know you're seeing it in the banking. It's a different world, and people have different mentalities now to the workplace than they did prior to COVID.
Well, I was going to say one thing. I should have said this for Dr. Duncan since we started the presentation, but, you know, I do good as David knows, because I have to come up here and have people help me with my, how to get online with my board, but, you know, I'm an IT person, but I spend a tremendous amount of time, and I know, you talk about industry changing, cybersecurity and all that, David, we talk about all the time, my IT people, I spend more time. You think about banking, you think, gee, I got loan officers, I got multiple locations. What it is, analysts and all that. We're as scared from cybersecurity and just keeping update from the competitive world. And I tell David that, I think Trent, you asked it earlier about talking about with Dr. Becker, for God's sakes, think outside the box. Chuck, you gave him the direction. You know, just because we've done it a certain way, talking about a claim, I'd say the same thing with IT. I'd always look to David and his people to come back and say, it's not just about the money, but to protect this institution, we need to do this and to stay on the cutting edge. So knowing full well our patients need to have access, easy access. Steve, I agree with you, but IT can hit you just, I know what I spend. We never would have thought we'd be spending what we're doing nowadays, but it's just the real world. But again, Dr. Duncan, I apologize for.
No.
The next factor is just as important as anything, it's our employees.
No.
It's probably, yeah,
No.
thank you.
Good point. As Robert said, I think I pulled a short straw, and no, in reality, when we were talking about the agenda, Robert asked, who's going to, once Alex had left, who's going to be presenting our best place to work? And I said, oh, I will. And it got really quiet. I mean, it was like Robert and Sharon were like so silent. They didn't know what to say. Robert didn't want to insult or anything else. But yeah, if you look across the organization at the executives, I'm probably one that has a lot of opportunity to spend time with our people and slow down a little bit. But they are a big investment. And we heard that with the acclaimed presentation of how big of an investment that we need to put into our physicians, but more importantly to the employees that also support those physicians. And so I want to thank you for just giving me a few minutes to talk about how the budget asks for next year align to the strategy to be a best place to work. I think it's important, as Robert said, across the nation we are seeing changes in the workforce, and so I think it's important to begin with what I see to be two big changes that we see now at JPS. And number one is the number of millennials that have come into the workforce. We have over 60% of our workforce right now are millennials, and just to remind you, those are individuals that were born between the years of 1981 and 2010. And we have over 40% of our leadership team that are millennials. So we have a considerable number here now, and we've got to consider that when we look at new retention and hiring strategies. Just to put some context around this, in 2015 here at JPS, we only had 36% millennials. So in less than 6 years, we've more than doubled the number of millennials. So it becomes important as we look at recruitment, compensation, retention, and engagement strategies that we have this large millennial group and that they look through a different lens than many of the baby boomers and Gen Xers looked at many years ago as they were looking for their jobs. Millennials, unlike baby boomers, they really live in the moment. They see their job as being both their career and their life. And if any of you have children that are baby boomers, you know that. They often talk about spending their weekends traveling across the country and not really spending time on work. So they are attracted to more flexible work schedules and environments, and so we'll have to have some new strategies around work from home because they will be asking for that. And they will also look for more job sharing. They don't depend as much on their salaries to live on. They do have parents that they continue to live on. No, it's the truth. Mine is yet to come off my payroll. I always ask him, when is he coming off? He looks very closely at my retirement plans. He asks me about them on an ongoing basis. I've got to give him dashboards and everything else around this. Yeah. I mean, it's a different world. Millennials are more ambitious. We don't talk about them being hardworking, but they're just more ambitious. And so they're seeking jobs that offer and promote career development and advancement. So we'll need to develop different and targeted career development tracks and programs. And they really want to take on challenging jobs really early in their careers. And they really want to be coached. And so we'll have to have programs that address that. They are more likely to accept lower pay if the job gives them a sense of meaning and personal fulfillment. And so they are looking for strong cultures and mission. And so JPS really needs to capitalize on their strong culture and mission when setting up recruitment strategies. I think we have something in place there. When it comes to compensation, they will be more interested in fairness and equity than in actual pay. And we'll talk about that a little bit later when we talk about compensation strategies. And it's probably why it has risen high in our organization with employees really expressing equities in pay. They're born into the technology world, not like, besides maybe Roger, many of us were not born into that world. And so they expect their workplace to be technology savvy. And so we will have to invest in technology. And we heard from David kind of how he's beginning to do this. And they will spend, on average, only about 2 to 3 years in the workplace. So you're not going to see a lot of loyalty. And so when we look at strategies and we talk about retirement plans that vest at 5 years, that's probably not going to appeal to them. So we're going to have to look at our benefit packages a little bit different. The second big change in workplace that I want to talk about is how organizations are addressing diversity, equity, and inclusion in the workplace. And as we know, over this past year, we saw a lot of social unrest around social inequities and disparities. So we know that our workforce represents a diverse race and ethnicities, but there remains here at JPS considerable work that still needs to be done to move diversity, equity, and inclusion to the core of the work that we do, and not as something that is separate and peripheral. So diversity, inclusion, and inclusion should be a part of our HR policies, our engagement, our retention programs, and we'll need to understand how this plays out differently among different races and ethnicities. And our DEI programs will also need to help drive and set recruitment and hiring practices, how it is that we train, how we develop different ongoing programs and procurement practices that Reverend Emerson has talked about quite a bit. We'll need to tackle that. And Lauren will present to the full board in August the scorecard that we have developed for diversity, equity, and inclusion goals and metrics. So I think that's the first time that we'll see that at JPS, in which we will start to have scorecards and goals around that. So if we can go to this slide here, I want to move on to really speak about where COVID left us. And around vacancies and recruitment, we have seen, and I'm sure that you have heard about, just a really high number of vacancy spots. And so those are big challenges for us. And we've also seen those high vacancy rates in our RNs in more difficult positions such as critical care, ED, and oncology areas. And so this will be a real challenge for us, because without our bedside nurses, the quality of care and our ability to care for our patients will be compromised.
How are those COVID-related vacancies? Did they go somewhere else? Did they go home and not come back? I mean, what happened?
Yeah, there's been a real, and we've seen this not only in healthcare, but there's been a real slow return to work. And so some of them did go home to care for their families. As the kids were sent home, they needed to be at home. There was a lot of movement in shifts during COVID with our RNs, and so as states started to surge, we started to see many of our RNs, especially in our ED area, leave and go because there was high pay and high incentive. And again, there was a real slow return back here to JPS, and so.
With the retention of folks and how we do that, salary is not the main thing, in my opinion. Because let's say that we raise the pay for nurses $2 today. Texas Health Resources will do the same thing in 2 weeks, only they'll raise it $3. So we're always trying to compete in the marketplace, but even when we're at the 50% of salaries and whatnot, we're always at a disadvantage because we cannot keep going up. So the other things that we can do here are incredibly important. And the way I look at it is job satisfaction and happy employees and engaged employees are the main thing that we can have. Sorry, I just...
No, I will say, Mr. Chair, I don't disagree with you, but the challenge that JPS is facing is we can't not address it and get that gap greater. If we can be in the marketplace,
right,
that engagement and that willingness to want to be at JPS can help us retain good employees. But if we're not understanding that Baylor and THR right now are still in our ED team by signing bonuses and $3 and $4 and $5 and $10 more an hour, we are losing folks. So I agree with you 100%, but we also have to be close to that marketplace or we're in big trouble.
Yeah, Robert, the other thing, I agree with Chuck and what he said, but in the real world, I'm in a competitive environment, there's banks on the corner. I don't compete just against the local banks, I compete against Wall Street banks. If you're gonna have the right talent, you're gonna recruit the talent, you gotta be competitive. Now, this competitive means we're paying 40% above market, no, but whatever our gap is. Yeah. And I'm sorry to say this, most people kind of like where they work. They don't work just for the money. So you got to have all the things we do in this organization to support people. But at the end of the day, and I think Karen hit it right, especially with your millennials, it's show me the money. And don't tell me about to go watch 30 years from now.
what are you gonna do for me? Because I'm trying to buy a new house, a new BMW. And I'm not picking on the millennials. As you know, I got 2 lawyer sons, and they're in that age bracket. But the reality is, I think, Chuck, we gotta be, whatever that competitive, I don't know if it's 2% off, but it's not 30% off. That's just my personal opinion. And the other thing is this, even though our employees love us at JPS, there will be an undercurrent that we don't think we're not paying them what they could go get someplace else. That's just my personal.
It's a value deal.
Yeah, I'm not saying we gotta be more, but we gotta take care of our people. That's just my personal opinion.
Yeah,
It's a combination, Chuck. I agree with you. I'm agreeing with both you and Robert.
plus I think we have to also take into consideration is the bond program. And our facilities also are competing with the other facilities in this town.
I have a
All
question.
good challenges to address as we go forward. Right. We got staff to do it, and we need to address it.
Talking about retention and all that stuff, when Dr. Johnson was here, we talked a lot about physician burnout and all that stuff. And I think we haven't talked about that lately, but also I think we need to look at the younger population that we have working for us. Even though it's motivated by passion and, by social stuff that they want to do to benefit the environment and everything else. But what I learned a hard way is that they work very long hours. They don't want a once or twice a year performance review. They want it every month so that they can have a chance to adjust. They don't want to make money but pay them fairly. That is a very, very hard thing to digest. Because to them, fairly is you tell me what I need to fix, I fix it, I gather more stuff to do, I do more stuff, and they turn around and say, pay me more. And it's very unrealistic because we have an 8-hour work day just because we don't want them to burn out. They need to learn about not just their skills, but how to do budgeting, how to deal with other people, how to do other things so that they can learn how to move up to manage people. And I don't know how, do you guys start looking at that kind of program to advise and counsel internally and making sure that things line up that way? Otherwise, in a few years, they're gone. And if we lose the younger one, we lose middle management in the next 5 years also as well. So.
Yeah, and I alluded to that, they are really looking for, to your point, fast career advancement. And they are looking for the workplace to develop them in place and to be ready to move on, whether it's within that place, we'd like to retain them, but to move elsewhere. And they want the coaching. So they want to move into a higher level of work and challenge, but they want to be coached at that level. They don't want to wait for you to say you've got to have experience, you've got to go back to school. Their plan looks very different than it did for the Gen X and for the baby boomers. So we do have to look at that. I mean, I think there is opportunity for us here to look at a lot of our leadership development programs that we have. We've had some good basic ones, but we've really have got to match it to what our employees are asking, and the majority of those employees being millennials. So they're not going to wait 30. No. They've watched their parents. They're not going to wait.
Are you focus grouping just those people, or?
No, and to your point, Roger, I don't want to make it look like all of our strategies will be around that. Now, we are seeing an exit, when you speak about burnout, we are seeing exit of baby boomers, probably for a number of reasons. They probably have, they went a full year without traveling at all, seeing their grandkids and whatever, and so I think that they are moving quicker to get out of it. They often are in leadership positions and they're really not as technologically savvy or quick as some of the millennials that are sitting next to them. And so they really are making, we're seeing a lot more of them being ready to retire and actually doing that. And that's going to be problematic in itself because we really need them to be able to coach a lot of the new individuals, especially the millennials that are coming in. You have to be,
I express that because there's a big difference between smart and wise.
mhm.
I think they skipped that last part. And it's almost like, Mhm. and that's a very difficult to maintain a consistent, to raise them to the level where they can manage. It's not about themselves, it's about the people that are going to be asked to manage and give guidance and all that stuff also as well. Otherwise, they just subject matter expertise. And then in about 10 years, younger kids coming up, and they're going to find themselves can't find a job. But that's reality.
And Charlie, you spoke a little bit about that they are out there and they do see salaries that are more and they're moving to it, and we do have to understand that that is occurring. But that really, we really saw that with some of our lower wage earners, that even 50 cents could quickly move them from here into another place and another position. And and we've worked hard on decreasing the time in which we offer the job to the time in which they can start working, because we found that places that were doing that better than us, that they were actually able to pull it as we were working through that onboarding time. And so.
I just want to say that, and again, I think we've got to be competitive, because we do compete, and we want to make sure our employees know we think they're just as good as they are, if not better than other place else. I think sometimes if we're not careful, I'm in the world, got a bunch of millennials, they're fun to work around. They're smart, they're aggressive. And like I say, all the models are changing, paradigms are changing. You don't have to spend at the same time. Technology has brought them quicker to what may have taken my generation 15 years to become that in that job, because they needed that experience. They're picking it up quicker and they're smarter when they get in the game. So I don't want to say, I think there's a combination. Like, they're fun to work around because they push you.
Yeah.
But you can't tell them you're going to wait 10 years to move from that job to that job. They're saying is, give me the roadmap and I'll get there quicker. I mean, they're very challenging in what they do. So to me, they're good for the workforce.
Yeah.
We don't want to run off our more experienced people, but you got, like you say, you've got to have some kind of mentoring development program. You're not going to keep all of them. Just like you say, some of the boomers are getting out for whatever reasons. But with that millennial, those incoming, you got to give them opportunity, or you'll spend all the time training them and we'll lose them down the street. And then it gets more expensive, as Robert pointed out earlier, any profession, any business, if you're doing all the training, somebody else is picking up your talent. That speaks a lot for your organization, but they get jobs.
Charlie, is when you lose them, you lose all the training you put into them, and then when you bring them back, you pay a higher rate. That's right. And that's the problem we're having right now, and that's what Karen alluded to. We have policies where unfortunately we have people that they leave for a year and a half, they come back, and they're making more than everybody they worked with. And we've got people training people here who are making less than the people they're training. And that's got to be something that we dig deep down into the HR catacombs and say, stop. We can no longer do that. You can't keep this workforce the way we need it to be if you keep those kind of policies.
The other thing that is really interesting, especially with this particular population, is that they are, yes? Yes, closer? Okay. Hello, good morning. I know, everybody's looking at me like,
Good morning,
I
really is.
I did. It's been a long day.
I'm not starting this over. This is good afternoon.
I'm not starting.
Well,
I came in on the last page, y'all. I came in on the last.
Maybe, Roger, she's actually right. We've been in here so long, it is morning. We just didn't realize
You've
it.
been, I did. But one of the things about this particular population is that they're not only looking at the amount of income that they're making, they're looking at the diversity. They're looking at, they don't want to be the token. We've talked about this for years and years. They don't want to be in an organization where they're the token. They want to be ready and down and dirty and getting through work. They want to work and they want work-life balance. And they want to figure out what does that mean and how to do it. And like you said, Charlie, in the quickest possible way, because they are ready to fire themselves, which is the FIRE movement, freedom, independence, retire early. I'm not trying to work until I'm 70. So, yeah.
It's something to change. Everybody's got different
ball goal or a putting green in my analytical department, but I got MBAs and they're just brilliant and they got all that, but they're back there working on those computers all day, running credit stuff. You know, if they want to get out the putting and have a competition at lunchtime, that's okay. So we let them design their department. Because in the old days, us old guys in this case would go in there and say, well, we got all this experience. We're going to build this big fancy, we need all this mahogany. They don't care about all that furniture and how pretty the mahogany is. They want to go give us the computers, give us our jobs, tell us where we can get to, because we're going to prove to you we can probably get there better. And I go back to what Robert said. We've seen a lot where, and it's, whether it's our industry or anybody, you can lose somebody, and then 3 years later, you're looking at them going, my gosh. But it creates my industry an issue because there's a lot of competition for talent. Healthcare's got a lot of competition for talent. The issue I hear more and more, because I've got the 9 banks. Well, Mary Ann's worked for us for 9 years, and we're gonna hire this incoming person in and pay her more than Mary Ann or Billy Bob. Well, that's the market today. Well, we haven't done a very good job, I'm talking about my industry, keeping up with making sure those people, because once you bring that new person in, you talk about how positive everybody works, you let them go have coffee together, and they find out.
They know within 5 minutes when
Yeah,
somebody came in.
Yeah, but I'm just saying,
It is
Robert,
like- it's
I agree with you, Robert. I don't know
overnight
what
since
that is, but it is showing up more and more in all of our industries.
But also the ERG groups and the
Yeah.
affinity groups of an organization become really important, especially in creating that cross-culture.
Yep.
That's what this kind of younger Gen Z is really looking for, is community in their workspace. They don't need to always be with everybody, but they want to feel like they're advancing, or that they have an opportunity to advance and meet other individuals at a higher level than themselves. It's very, like, again, I'll go back to your knowledge, which is great. They're ready to climb, and they want to figure out how to do that, and they want to be around the people that they know that they can. So we need to be able to provide them opportunities to do that, and especially in medicine, especially in healthcare administration.
No question.
That's going to be really important.
And I hate that word used to. Used to, we did it this way. You know,
Yeah,
you
no,
gotta
they don't
mentor them.
really, respond
They don't
well
really
to
want to
that.
know how you did it 20 years ago. That's not that important.
Yeah, I just want to say, one of the things also we have to consider, even though we may think healthcare is unique within itself, what happens many times, we'll hire and bring individuals in here, and they learn the skills, and those skills are transferable to something outside of healthcare. You know, so.
Good point.
I just want to make sure, because you hear, I'm pretty close to millennial. I'm a zennial. And so I've had no technology and all the technology. But, and you kind of hear it just a little bit sitting here when you say millennials, like, oh my God, the millennials.
No, we're saying it very
It's,
positive.
yeah, I mean,
Very positive.
being careful not to, it can sound very derogatory. Not intentionally, but the media and everywhere else, like, oh, these lazy millennials, they're not doing it, whatever. The fact of the matter is, I've said this at a city council meeting, the first city that embraces millennials will be one of the most successful
No,
cities
I
in
totally,
America, because it's going to be the generation that will build more generational wealth than anybody has ever done.
That's why I said they're challenging, they're fun, they push you along, they help you. But, and you've got to you got to keep them in a positive environment. Keep all your employees, because if you divide your employees, if you put labels on people, like we only let the young ones do this, and you got to keep your team. And again, I go back, Robert, he runs a team here at the hospital, but I totally agree with you. It's not a negative. It's the future is what it is.
You gotta almost treat them like rock stars, because some of them
Really are. They really are.
That's right.
I'm totally impressed, and I mean, I have some around, and as you know, my team is strong. I mean, I have quite a few of them who really do make me look better every day. So I see it as very positive. And Amanda, to your point, if you look at this graphic here on your right, we do put diversity, equity, and inclusion, because they have opportunities to lead places that do not have individuals that look much like themselves, and they will go elsewhere based upon that, and they are looking and will leave if there's not equity and inclusion demonstrated in the work environment. And so it has to be at the core of what it is that we're doing, and integrate it into every decision we make.
And that also includes diversity of job elevation.
Yes.
And so all the way, the executives need to
Yeah, it's
meet with
not
front line.
overall
Yeah.
organization, but at every level, we've got to look where there's opportunities. Yeah, no, I totally agree. I am looking down because I can't read. I do have pretty good far vision, but just around turnover, as we said there, we are seeing increased turnover. And we're seeing that turnover really in the first year. And so it really speaks to how engagement really needs to start at the time that they drop their application. Many times we wait until they're here. But we really have got to start engagement and give them an experience when they first put that application in and begin to reach out to them, because otherwise we will lose them early and sometimes even before they get here. And then engagement, we talked about how Amanda spoke to how they really are engaged in workforces that have strong diversity, equity, and inclusion programs and that they feel more a part of. And then around career growth. So with that, I think this has been a great conversation and a great segue into how we set our budget for next year, taking into account what our workforce looks like and then just where COVID has left us. And so what you will see in the budget ask are, first of all, recruitment dollars for the new Senior Vice President of HR, so I will not be in front of you doing this, and then also a Vice President of Diversity, Equity, and Inclusion. We also will see additional recruitment dollars in the budget to help us recruit more diverse candidates. So we will look in those areas in which we have opportunities to have more diversity that are a little bit harder to recruit for, especially around areas like IT, and use recruitment firms that have bigger pools of candidates that we can pull from. And so that we do, to Amanda's point, really show diversity at every level within the organization. You will see an ask for increased contract and agency dollars because we have got to offset the vacancies, the high vacancies that we see. We will be working hard with our talent acquisition team to fill our vacancies, but we do understand that from a quality standpoint that we will need to fill those temporarily with contract and agencies dollars. There will be some consultant dollars and for a complete assessment of our diversity, equity, and inclusion program, and to help us begin to develop and implement some solutions that will help us operationalize diversity, equity, and inclusion to all areas across the hospital. And so we are looking to partner with an outside consultant firm to evaluate that. There will be some technology asks. David spoke of some around access, but there will also be some technology asks in order to optimize some of our technology platforms and better integrate. We've got a lot of platforms, digital platforms here, but they don't integrate well, and so they're not end-user friendly. And so we are looking to really make that more an integrated process and more end-user friendly. There will also be budget asked to invest in human capital management again, and this will help our leaders with being able to better hire on board, kind of time management and workforce planning, and so investing in some of that software. Well, no, we do not, and David has already brought in a consultant, and we've had a lot of conversation around just bringing that software in here that allows our leaders to help manage that workforce and be able to see where we're at in the hiring process. Right now, a lot of that information is manual, so if I ask for days to hire, it takes a little while for that team to pull that together. We should really be able to see, our leaders should really be able to see that in real time where it is in the hiring process. And help us around performance reviews and things of that sort, so that we can make some real-time changes. Also, just our data, our HR data analytics, we've got to enhance that. We have not brought you good dashboards and metrics, and we've not provided to our leaders those dashboards that allow them to make some real-time changes. The biggest ask to the budget will be just what we talked about, just kind of how will we move forward around compensation strategies. We have been proactive in looking looking at this, and probably over the last 6 months, we've worked with an outside consultant team and with our benefits team to look at different compensation strategies that would make us more competitive and at the recruitment and retention level. There are
Here, let me ask you a question about that, and I don't know if this can be quantified or not, but we've historically maintained that target 50%, 50 percentile market. Can we quantify what it would do to our vacancy rate if that were not 50%, if that increased?
You're saying if it was higher than 50%? I'm sure we could, yeah. Yeah, we could just would move the
I
target.
mean, if the number one issue, and you point that out here, is compensation benefits, and we're having a hard time hiring people, and we're assuming that we can continue to do it at 50%. The question is, philosophically, is staff willing to look at a higher level?
Sure.
We can, and Trent, part of,
Yeah, and I was going to speak to kind of the two big strategies that we were going to look at. One is around just doing that market assessment, and then also doing the equity review that needs to go along with that. We traditionally have done those. We've not done them together, which I think has offset and created some of what we are currently seeing. And so we are looking to do those together and to make those adjustments. But part of that really does look out there at the market and say, where are we in comparison to it? And then we can set that kind of 50 percentile. I think it would still probably be a 50 percentile salary range for us.
Comparison.
Yeah, part of what we are proposing, and you'll see when we present you the budget, is just the cost of reevaluating to make sure we're at the 50th percentile. But we will calculate, we'll try to, it's complex, but we will try to estimate what maybe a 60th percentile or some other target would cost.
To whatever extent that it's actually empirical.
Yes.
If I were having to operate my business today on the 50 percentile, I couldn't run it.
Yeah.
I couldn't run it. It's that simple.
But how do we do it quickly? I mean, I said, how do we do it quickly? Because we're 6 to 8 months before a consultant comes in here and does all their thing, and then, we're a year later.
Another 10%.
Right.
Yeah, so we've already engaged, we've already started that work in anticipation that the board will approve, this ability to adjust according to what the market assessment and the equity review provides. So our teams have already started working on that. It will probably take us several months, not only to complete it, but to review it and make sure that there aren't any outliers across the organization. So we have already started that work in anticipation that that will be approved. So.
Is there an opportunity one of the companies, especially like California, in around the LA area back then, we have such a high turnover, over 37%. So what I did was I changed the benefit policy to cover for same-sex partner. We brought that number way down from the following year. And then there are cases where we have area where we couldn't hold on to people because middle management was weak and nobody wanted to work there. Is there a place, opportunity that we can try some of that in area that have opening or something like that to see if we can upgrade the skill set and measure against what we've done? Because I'm a firm believer, if you can't do the same thing all over again, expect better result. But, compensation is key, but other area, if we try one area that has an opening to see if that lift up something, and then over time we know to put more leadership training and stuff like that, to invest in our own people, to be able to know how to manage people correctly.
Yeah, no, I think you make a good point that when we speak about benefits, not just retirement plans or health plans, but just really around that career development. I think that we have to speak to those things that we plan to invest in and see it as an added value to the employee. I think we also have to be creative, and we've worked hard here to be creative in those more difficult areas to recruit. Our respiratory therapists, for example, that was a really hard, we had a number of openings, as many of them also kind of left to go to where the surges were at, but, we looked at, much like other companies looked at kind of signing bonuses, different ways of looking as to how we can just even get them here to begin looking at JPS. And so we've looked, depending on where our vacancies are and how critical it is, at different ways of attracting them here. And I think we have to continue doing that.
So what do you think about Pastor Emerson's comment earlier regarding the relationship between retention and facility quality? I'm sorry. My question was, what did she think about Pastor Emerson's comment regarding the relationship between facility condition and retention? Go ahead, speak candidly.
Yeah, no, I'm just trying to think about this. I think sometimes nice facilities attract you, but they don't necessarily keep you. And so I do see, and I don't think this has to do anything with generations, but I do see that it's more about, does the organization provide me the resources I need in order to be able to do my job? Does it provide me the laptop? Does it have the software? Does it make it easy for me to do my job? And then some of those other softer things, such as, do they make me feel, that, do I feel important? Do I feel a part of decision-making? I do think that facilities draw individuals to a place, but don't necessarily retain them. I mean, when we build a new, something new in the area, even though you may have shopped at a little store that didn't, the aisles were real close and whatever, you get a big new thing, it'll draw you in there, but it's not what really keeps you there. You often will return to where you have comfort and where people treat you in a certain way, and so.
And to Karen's point, and I agree 100%, there's a little bit of another factor too, in the sense that if some of our doctors were able to look at an ambulatory surgery center, for example, and be able to take some of their patients that may be going elsewhere and they would want to have them here, but because it's challenging with only 13 ORs, they're going to get bumped, so some of those patients aren't going to do that. If you look at the convenience of the center, not the aesthetics of it, just doing things smarter, I think it would make for a better workplace, and I think it adds to it. I agree with Karen 100%. Glitz and beauty won't do it, but being a more efficient system, just alone allowing JPS to put all of its acute care on one side of the street and not moving people all around is a much better workplace. And if you don't move so many people as we have to move now, you wouldn't be pulling nurses off a bedside and other places to move patients. So I think it adds to the quality of the workplace, but I don't think just building a new building, one can expect that you're going to have a retention of your employee base.
Well, it's not going to hurt.
No, it won't hurt, and I'm not.
Because there's not a lot of people that just, love working in some of the conditions that we have today.
Sure, no doubt. And if we look at other public hospitals post-bond in other communities, you do see a patient-payer mix that increases as well. So there are definitely advantages. I'm not diminishing it. I think it's a factor, and I think the efficiencies of your buildings and the smartness of your buildings. You also start looking at other issues such as security, where your parking lot is parked, where you are from. I have to leave at 7 o'clock at night and walk across a place that's a little bit darker or puts me in fear. All those are factors to the quality of a workplace.
Well, and people my age we like the new and shiny. I'm just saying. We like the new and shiny.
This is a great point, because as we talk about physician engagement,
right,
we start looking at all those variables. What are those variables that have a physician comfortable with bringing more of their commercial patients
Part of the problem with commercial payer mix is our doctors want to be here and they want to bring their patients here, but without an ambulatory surgery center, it's harder because you are going to, and Chuck can speak to this, you are going to get bumped more frequently here, and the quality of that is going to be reflected on the patient to the physician conversation, and they don't want that conversation. So if you ask them, would you like to bring your patients here? The answer is yes. And they want to do that. They just want to make sure that they have some stability to their patients getting in.
That's a great point. Let me give you a quick sort of study about what you just said. Fernando Garcia, surgeon here, and I were both kicked off a health plan. And we were kicked off for the following reason. We were keeping our patients with acute cholecystitis, gallbladder problems, in the hospital too long. The reason they were in the hospital too long was they kept getting bumped on the OR schedule. So as soon as we could operate on them, they'd be home the next day. But that didn't fit the algorithm of being out within 48 hours. So Fernando and I were kicked off. So that's the type of thing that you don't think about very often, but I'm sorry, thank you.
Thank you.
Karen, I'm going to go back for a second when you talked about securing in those consultants who are going to do some of the work in inclusion and diversity and other areas. Let me tell you a quick little story. The city of Fort Worth has pulled a group of individuals together to do some pre-planning.
All right, what was that?
Technology.
That was the city of Fort Worth.
To do the pre-planning for guilty or not guilty verdict with the trial that's coming up, the Tonti Jefferson's murder, or killing, I should say. Well, so they had about 15 to 20 people around the table. And I said to them that you had the wrong individuals around the table. First, you got me, I'm the wrong guy, because however it goes, I'm not marching downtown. So you don't need to plan on how to address me going downtown, marching. My body does not accept those bullets. I said, one of the things we need to do is bring to the table all of those groups that we perceive will be involved in the march. Black Lives Matter, Enough is Enough, can't think of all of them now, but it's about 5 different groups. Bring them to the table and let's talk about this now. I say that because those consultants that we get need to be able to find those groups in the community that they can talk to that are millennials, that are qualified, that they can also recommend, as opposed to just doing searches. We will need to reach out to those bodies to do that. There are groups that Amanda knows, some that I know, that we would like to be a part of, is at least giving them some recommendations to that, so that they are aware of those different groups. As an example, it's not just Hispanic chamber and Black chamber. They basically have outlived their usefulness. Okay, but there are those groups.
That's an interesting comment.
There's the East Side Connection, there's the Stop 6 Connection, and these are all millennials. And matter of fact, I'm a member of them, so I show up at the first meeting, they thought I was lost.
And they help guide you also.
Yeah, so I just want to share that's the area that they need to look at when they talk about doing that research and getting out in the community.
It sounds like we need millennials on the board.
Well, you're not going to get millennials on board.
No, I just wanted to see what
I think we have a
That's
couple
the closest
close
we
to
got
it here that, yeah,
Till the
that
county
hurt.
commissioners change, you're not gonna get it.
I know, I
I'm
know.
too
I
Cannot fix your laptop, thank you.
Now we've really gotten into.
Does that count?
And it could be why Roger was so sensitive about the millennial conversation. He may have taken it personally, but, yeah, two millennial,
Added
okay.
together, he's two millennials right there.
Let me just say something.
Ralph just made a
It's
very
not the obvious
intriguing-
things that we're gonna get in trouble with. It's the unobvious things, the unintended consequences. Give you an example. There was a company that had labor grades, and within those labor grades, they had ranges, 26 of them. And they decided that 26 was too many, so they changed it to 6. Now, the unintended consequence was, instead of having 26 promotions in a period of time, you may have only gotten 1 or 2, and it would take longer to get that promotion. So some of the things we culturally do for the right reasons turn out to have the wrong repercussions. So we need to be cautious of the unobvious things and make sure that they don't be detrimental to what we're doing.
Totally agree. I just want to just speak to one other compensation strategy that I do see to be really important and high on the list, and that is around living wages. We currently, our minimum wage is set here at $11. If we look around the local area here in the regional area, we are really at a low minimum wage compared to others.
We're at a very low.
Minimum wage.
I'm sorry, minimum wage, yes. For example, cook children, and this is a moving target, and we have not moved, but it's a moving target. But cook children, minimum wage was at $13.25 last week. They have moved to $15. Buc-ee's, Chipotle are now at $16, $17, $18. So you can only imagine how difficult it is for us to get in some of our EBS workers, our linen workers, our techs, our food service workers. We just are not attractive at all. And so we have looked at internally at what that would look like and where we should be, and we're closing in on that. But that will be part of our compensation strategy consideration, and will come forward most likely as part of the budget. We are including our contracted EVS help. We've always included them in our AIPs and anything that we do, and so we've reached out to them. But I believe it's around 342 employees that we are speaking about that are affected by it.
342?
Yes, about 342.
Our approach is that sends quite a message, and we're very committed to that. So what we want to be able to do is, when we go into the future meetings, give you a little more detail on that, but we wanted to introduce it to you all now to tell you that's not where we want JPS to be. And it's nothing wrong with any of the other industries. There's nothing wrong with Buc-ee's and what they pay, and Chipotle and what they pay. There's something wrong with what we pay. It's not where they're moving, it's where we need to go. And so we're convinced of that. So we'll give you all the details of that in future meetings, but I think that sends quite a message to this organization, because you got to look at every level of an individual coming in these front doors and pay them fairly.
Is there an opportunity, because we have a lot of job opening also, is there an opportunity to really look at all that stuff and look at to see how can we redefine our workforce? Because sometimes instead of 3 or 4 jobs, can we do that with 3 and pay them a lot more for the budget that we pay for 4? But we ask them to do a little bit more by redesigning or making the job more fulfilling type things. Because otherwise, we're just going to be filling in body, and it's a body job.
Yeah, we've talked a little bit about that, just even how do we move an EVS worker or a food service worker into a tech job or into the next, job with training, certification, and paying for those. So.
Filling the gaps and just redesign the workforce and expect a little bit more so that you can shrink the workshop, but actually make it more meaningful work for them because, it's not confined to certain things, but pay them more. And the savings they are financed for that. That may be another way of doing it. I think some of them are already doing it because if you have a workforce, that you have less people, then they're already stepping up already.
Yeah, they're always stepping up. No, you're right. You're exactly right. And even when we moved a large part of the workforce to work from home, we still saw that we had almost better productivity and outcomes and did not need as many people, so.
Well, my comment is going back here, and I think I started this with saying, I want to support the fact that we're moving toward competitive compensation. It's not just for the top C-suite people. I like the fact that we're comparing someone to leaving this hospital for outstanding jobs. We've heard some people get outstanding jobs, and we've heard their salaries. I like the fact we're looking at all our employees. Be sitting here comparing our employees to what Buc-ee's is paying. That's still a competitive pressure out there. We need to look at that. So I'm glad we're looking at the whole thing. The only point of reference and clarification I'd like to make is I think we ought to be competitive to the marketplace. DT brought up California. I'm talking about here in Texas because I know what they pay in California. So anyway, but I commend you for what you're doing. We got to look at the whole compensation for all our employees.
I think we need to look at it for all the employees, but I also think we also need to look at our philosophy, because I don't think the 50% where we target where we are is the correct target now, because the world has changed. So we look at all of that, and that should be a part of this budget, because we're going to need to make some major decisions.
Also, one of the important things, especially when we're looking at raising salary to $15 an hour, what are the benefits that are coming in for these particular employees? We can do a lot with offering an IRA, a SEP that doesn't have to be a full retirement. You can do bonus pay to an IRA Roth. Many people have that. That's not necessarily a traditional bonus package for a lower wage employee at that time, but it can get creative. We can get creative, and we can get opportunities so that there is some type of retirement option. I was really sad when the IRS ended their individual IRA plans for individuals who were part-time workers. We did so many of those types of plans because there was a hunger of individuals who are working 2 to 3 to 4 jobs trying to piecemeal, but they want to save. They want their retirement package. They want to be able to put something away. So when we look at things, we can be creative.
That person could be a part of the connection program somewhere. Many of them are working, can go nowhere to a doctor. So I think that would be key.
Karen, thank you. I think, here's the funny thing about Karen Duncan is she'll tell you she can't make these presentations and she doesn't want to make them. She does an excellent job every time she makes them. So I'm not necessarily buying that she can't do this. She knocks it out of the park. So thank you.
Thank you all for your comments. Talk about retirement, being a baby boomer retiring, I'm just telling you, it's just like, I have to do what? I thought they'd come to work ready to work. I got to do what?
Chuck, I want
But
to
they will be taking care of me in the future. So.
There's one thing that David didn't talk about in his budget presentation that I was hoping he was going to include, that if you would just please add in a personal lavalier for DT.
Right. David, I missed your presentation. Can you please present again?
I'll pass the mask.
Mendenhall, thank you.
Thank
And
you
it-
all.
with that, we're adjourned.
No executive session.